Wel, bore da a chroeso i chi gyd i'r cyfarfod yma heddiw, sef cyfarfod bwrdd iechyd addysgu Powys. Ac fel y gwelwch chi, mae'r cyfarfod yn cael ei ffrydio yn fyw o'n gwefan ni, ac yn ôl ein harfer, mi fydd na recordiad o'r cyfarfod ar gael i'w gwylio yn dilyn ein digwyddiad heddiw. Carl Cooper ydy yn henw i, a fi ydy cadeirydd y bwrdd. It's a great pleasure once again to welcome each and every one of you to today's meeting of the board of Powys Teaching Health Board. And as always, we are live streaming this meeting, and it is therefore accessible from our website. And a recording of the meeting will also be available from our website to watch after today's meeting. My name is Carl Cooper, and I am chair of the Powys Teaching Health Board. Ac yn y man, fe welwch chi hefyd ar y sgrin manylion o'n cydweithwyr annibynnol ynghyd am cydweithwyr gweithredol, ac hefyd enwau bobl eraill fydd yn mynychu ein cyfarfod ni heddiw i gefnogi ambell i eitem ar ein hagenda. Yn ogystal ac ei enwau cydweithwyr sydd yn methu bod gyda ni heddiw, a dyn ni wedi derbyn eu hymddiriadau am absenoldeb. You'll see now on the screen details of board colleagues who are present and will participate in today's meeting, both independent member colleagues and executive member colleagues. You'll also see details about other people who will attend our meeting to support various items on our agenda, as well as some colleagues who can't be with us today, and we have received and accepted their apologies for absence. And before I go any further, I would like to say that it's a particular pleasure today to welcome Rhiannon Beaumont-Wood, who is my new vice chair colleague. And Rhiannon comes to us, and this was I included in my written report to the last board meeting, but she joins us with a wealth of clinical, executive and non-executive experience, knowledge and expertise. And Rhiannon, it's a delight to have you as part of our team, and we really look forward to your contribution to our work and to helping us fulfill our responsibilities over the coming years. Croeso cynnes iawn i chi. So, pam ydyn ni yma? Be di ein pwrpas ni fel bwrdd? Wel, ni ydi corff llywodraethol y bwrdd iechyd. Ac fel wedais i gyne, mae'n haelodau ni yn cynnwys aelodau annibynnol yn ogystal ag aelodau gweithredol. Ac gyda'n gilydd, ni sydd yn ffurfio y bwrdd undebol. Ac fel bwrdd, mae gennym ni lot o gyfrifoldebau, ond yn bennaf, mae gen ni 5 cyfrifoldeb. Yn gyntaf, dyn ni yma i osod cyfeiriad strategol ar gyfer y sefydliad. Yn ail, dyn ni yma i osod archwaith risg yn erbyn cyflawniad ar amcanion strategol hynny. Yn drydydd, dyn ni yma i fonitro ac i graffu ar gyflawniad ac ar berfformiad yn erbyn yr amcanion strategol hynny. Yn bedwerydd ac yn bwysig ofnadwy, dyn ni yma i liwio ac i fodelu naws a diwylliant y bwrdd iechyd. Ac yn olaf, ac nid yn lleiaf yn sicr, ond yn olaf, dyn ni yma i sefydlu ac i gynnal safonau uchel o lywodraethiant corfforiaethol. As a board, we are the governing body of Powys Teaching Health Board. We have a lot of duties and requirements and responsibilities placed upon us. But in a nutshell, we have 5 headline responsibilities, if you like. We're here to set the strategic direction for our organisation. We're here to set the risk appetite as we deliver against those strategic aims and objectives. We're also here to monitor and to scrutinise the delivery against those strategic objectives and our performance in relation to them. Very importantly, we're also here to set the tone and culture of our organisation based on the values that we take very seriously and that we hold ourselves accountable against from day to day. And lastly, again, very importantly, we're also here to make sure that we establish and maintain high standards of corporate governance. Now, our board meets in public in line with NHS Wales regulations, but perhaps it's helpful and important to draw a distinction between meeting in public and this not being a public meeting. And so the only people that will participate in today's meeting are members of the board and those, as I said earlier, that we have invited to support various agenda items during the board. However, our connectedness with our population and the citizens of Powys is of fundamental importance to us. And one of the ways in which we do that is that we invite questions from the public for us to consider as a board in each of our meetings. And if anyone would like to find out how to submit a question, then that information is available on our website. Our meeting is being live streamed, as I said earlier, via Microsoft Teams, and the board operates also a consent agenda. And so later on in our agenda, you'll see that there are a number of items under the consent section, and those are items that we have recognised as not needing necessarily discussion or conversation today, and can be taken en bloc and either approved or noted or recognised, whatever the recommendation is, without discussion. Of course, it is always possible for any member of our board to ask that anything that is currently in the consent section of our agenda be removed from that and therefore become a substantive item for discussion on our agenda, should any member wish to do that. Ac felly, yn ystod, mae gen ni lot ar ein agenda heddiw, ond yn ystod y cyfarfod, mi fyddwn ni yn cymryd egwyliau, ac just ar ôl 1 o'r gloch, mi fyddwn ni yn cymryd egwyl ychydig yn hirach, i ni gael ychydig o ginio, felly, ond mi fydd hynny yn digwydd yn ystod y cyfarfod. We will take breaks during our meeting today. We have a long meeting and a packed agenda, and just after 1 o'clock, we will take a slightly longer break for lunch. So without any further ado, we move to our agenda, and as always, the agenda and a full pack of papers is available for to the public and for public awareness and use from our website. So if anyone hasn't had chance or opportunity to look at the papers, please do visit our website. They are available there. So we have dealt with the apologies and absences. So we go firstly to item 1.2 on our agenda, declarations of interest, datganiadau o fuddiannau, ac yn ôl i'n harfer unwaith eto, fe welwch chi yn y papurau ein cofrestr o fuddiannau. We have provided, as always, a copy of our declaration of interest register, where all of us declare any interest in that. But I am going to ask colleagues, are there any declarations of interest connected to any item on our agenda today that anyone would like to draw attention to or make us aware of? Rhiannon, please.
Diolch yn fawr, Carl. Yes, it's just a timing thing, I believe, because I have submitted my declarations to the Health Board. But just to note that I am in not too distant a timeline. I will be completing my term with Dorset ICB, but at the moment I'm declaring that interest, and I'm also a registrant member of the Nursing Midwifery Council, and I'm also on HEIW, or Health Education Improvement Wales's framework as a coach. Thank you.
Really helpful. Thank you, Rhiannon. I can't see that anyone else wants to draw our attention to an interest in relation to the agenda. So thank you. We then go to item 1.3 and our board action log. We'll see that there is one action there that is requesting a date change. And apart from that one action, there are two actions that are on track and one that's been completed. But Helen, is there anything that you or any other executive colleague would like to comment on in relation to any of those actions?
Oh, diolch, Carl. Good morning, everybody. Bore da, Helen Bushell, Director of Corporate Governance and Board Secretary. Just on the one that's at risk, it is a date change to September. We have discussed this item through Paul Hooton's leadership with the PECS, Patient Experience, Quality and Safety Committee. Carl, board members will note there's quite a long history to this agenda item. Some of that was because we were waiting for national frameworks to be released. Internal work has commenced. We just need a little bit more time to be able to accommodate both the provider and commissioner services that we deliver here in Powys from the perspective of patient experience. So the date change has been reported to Patient Experience Quality Committee, but it is required to be accepted here, returning then to the board in September. Thank you.
Thank you, Helen. Colleagues, does anybody want to contribute in relation to any of the actions on the action log? If not, then we move on and we move to item 1.4, which is always a really important and often inspiring item. It's where we listen to the experience of our staff colleagues and of our patients. And today we have a patient experience being shared with us. And I'm going to ask Paul Hooton, our Executive Director for Nursing, Midwifery, Women and Children, to introduce this item. Thank you, Paul.
Thank you, Carol, and good morning, all. Yes, I'm just going to introduce this patient story. This is one of our patients whose name is Amanda, and Amanda wanted to share her story with us in relation to when she had her baby and the postnatal support she got from the health visitors, in particular in relation to breastfeeding. And she highlighted in particular one of our health visitors, Laura Mulholland, within this, praising Laura's care and attention and support to help Amanda navigate the challenges as a new mom and breastfeeding. And within the story, you will hear the impact that this can have on someone from a physical and a psychological perspective as they try to ensure that they're able to feed their baby in an appropriate way with the challenges that faces, and the support that that she received from Laura was instrumental in ensuring she could feed a baby well. So I'll pause there and let Amanda tell her story.
Sophia was born 2022. I was really keen to breastfeed, but as lots of women, you never know how it's going to go. You might be able to breastfeed, you might not. Sometimes I feel like it's a lot of cases just down to potluck, whether it happens or not for you, and no fault of the woman. But it's something that now, since I've discovered that you need to be taught and the baby needs to be taught, and if there's nobody there to teach you that, then gosh, it's so hard to do. She was born, and then on the boob, I didn't really know what I was doing, and there were only two midwives on that night. One was a student midwife and one was midwife, and they were trying to teach me how to breastfeed, and we were trying all sorts of positions, and it wasn't going well. At one point, I don't think she'd taken any fluids at all. So the midwife said to me, you either give her some formula, which we packed in our change bag, or you try and get going. We ended up giving her some like instant formula, So that sort of gave us some fluids to get through the night, and then I kept persevering, and then eventually I think we did get going with a bit of breastfeeding, but I had no idea if anything was coming out. And then they discharged us the following morning, so we carried on with the breastfeeding at home, and the midwives came out, and the midwives around here are so nice. And she lost weight, but they said, don't worry, that's normal, keep doing what you're doing. I started noticing she wasn't having very many wet or dirty nappies, so I was like, is this normal, is it not? And then Laura, Mulholland, health visitor, who is amazing, called, I think, into day 10, and was like, oh, come over, Amanda, and have a look, see how you're getting on with the breastfeeding. Obviously, she'd been getting something in this time, because I think we'd maybe given her a little bit of formula, but we were mostly relying on me. So Laura came out, weighed her again, she lost even more weight, and she had this terrible rash from head to toe that had come on the same day that Laura arrived, and I just thought it was a rash from irritation of clothing. Laura took one look at Sophia and called the doctor, because she'd lost 11% weight, had this rash. At this point, I was a mess. I was like, oh my God, I'm a terrible mother, I can't do this. So Laura then sat with me, had a look at the latch. She said that Sophia wasn't really transferring the milk. She corrected the latch, really sat with me on this sofa here, and just went back to basics, got me going, and I basically learnt everything I probably should have learnt on day one, but obviously she needed to gain weight. And then it was straight into hardcore breastfeeding, breast compressions, pumping, you name it, to get everything going and to get Sophia gaining weight. Laura then came out again, 2 days later, weighed her, and she'd gained something like 20 grams or 40 grams. So we were like, hallelujah, the relief I felt, because I thought, oh my goodness, we're going to end up in pediatrics or something. She gained weight, and then I was just breastfeeding non-stop. I barely slept. Midwives plus Laura came out every couple of days to weigh her, and then she gradually gained weight, didn't stop gaining weight. But Laura just kept up that contact. She'd come here, or I'd go to the surgery, weigh her, just check, and everything then headed in the right direction. And then Orla came along, and same as I thought, oh, I'm going to be able to breastfeed easy peasy. Like, oh, I'm damned at this. Absolutely not the case. I didn't have a clue what I was doing. I put her on, and I was like, okay, I think she's sucking, but I don't really know. I felt like I'd never breastfed before. It was the beginning of a whole new journey. This is where perhaps I think, and it's through no fault of their own, or unless you're lucky enough to sort of have a breastfeeding expert in your area, somebody that really knows it inside out. The midwives, bless them, would come and look at my latch and be like, yeah, that's good, but I was in pain latching, so I knew something wasn't right. My nipples are getting really sore here. This, I don't think it is a good latch. But they were like, yeah, it looks like it's fine. And I thought, okay. But that continued, and then bleeding, and it got quite bad. So by day 3, midwives came. She hadn't gained any weight. But then I noticed the classic no nappies, or not enough wet nappies, no soiled nappies. Called Laura. Bless her, day 3, she came straight out within the hour. She came in, she sat next to me. I was totally engorged. I was in a right state. And she sat there, and once again, the basics, calmed everything down, corrected that latch, got me going, breast compressions again. And then all of them gained weight, supply kicked in. Absolutely amazing. She just, without her, I would have breastfed. I truly believe that. She makes you feel human, and she's so understanding and so kind, and she's an absolute gem in the community. And that unique set of skills she has, yeah, I wouldn't have continued, because I think that's what's missing in community, sadly, is that you need somebody who's almost like an expert, who just can look at you, your breast, the baby, and say, right, that's not quite right, that's why you're in pain, do this, bring the baby's head that way, get that, open and wide. And without that really specialist support, so many women will struggle. And with Orla, I would say I was hours away from being like, right, I'm going to go to formula. Can't do this, it's too painful. I felt like I had nothing to prove, and women should never feel like that. If you're in absolute agony and you're bleeding, you should be able to just go to formula. It should be, well, you're well within your right. So when Laura comes in and she corrects that latch, the pain goes instantly. The pain that you've had from trying to get your baby to latch, when you've got it right, goes. And then it gives your nipple time to heal, and then you're on your way. But something that's supposed to be so natural, it's really not. It's like a skill. It's got to be learned and taught. And Laura came to visit in April for Orla's 6-month checkup. and we'd had all 24 hours. And Laura came and I just burst into tears. I broke down. I sat there, Laura was there, and I just broke down into tears. And once again, she sat there, talked me through it. It was like, it cheered me up immensely. Gave me a list of like even just places we could go for walks on that were family friendly in the area. Next time you're having a tough afternoon, go out in the car, get yourself a drive through Costa, get them both asleep in the back and just sit there. And I remember her saying to me, look, if you ever need to talk again, we're here for mums as well. It's not just coming out to you in the community to look at your children, it's also to speak to mums and for you to be, and I was like, I just thought, oh wow, that's amazing.
Thank you. And on behalf of the board, a huge thank you to Amanda for sharing her story. Once again, a really, really important lived experience that we certainly bear in mind as we carry out both our meeting today and our business more generally. But Paul, I just wondered whether you had any reflections before we leave this and move to the next item on our agenda.
Thank you, Carol. I think it speaks for itself in terms of there's a number of messages and challenges and successes that come out in that story. What jumped out at me was in terms of, you know, when we're administering support and care to our population, it's that expertise, it's that patience, it's taking the time and the consideration and offering that level of support. And that came through really loudly from Amanda's story around how Laura spent that time and that patience and was able to apply that expertise. I think some other messages in there around the challenges our women have in our population in relation to breastfeeding, and one note there in terms of what Laura, what Amanda said around it's the most natural thing in the world, but yet can be extremely challenging, and that sense of frustration and failure, and how we can support patients and new mums through that process is really important. We did share this feedback with Laura, as you can imagine, and equally, as you could probably imagine, she took it very modestly, but was very pleased equally to have made such a difference. So I think there's a lot of learning in that story for us on a number of points.
Thank you, Paul. And again, a big thank you to Amanda, especially. So thank you for that. In which case, we go to item 1.5 on our agenda. I mentioned this in my introductory comments earlier. We have this standing item on our agenda, which invites questions from our population. We have received a number of questions today from a community group within Powys, Better Lives in Powys. Well, the first thing I want to say is thank you to the group for submitting the questions. Absolutely, really welcomed those questions. There are 14 of them, and so I'm afraid time constraints today mean that we won't have time during the course of this meeting to respond orally to every single one of the 14 questions. But I'm going to invite Helen, our Director of Corporate Governance, just to run through what the subject matter of the questions is, Helen, so that we have a flavour of that, and indeed how, as a board, we will respond to this group and how those responses will also be available publicly.
Thank you, Carl. Many thanks. And as you said, we welcome the questions we've received from the BLIP group. And in summary, the questions received cover the following areas. So they are in relation to the Health Board's cross-border commissioning approach into English providers. That really is the theme of all of the questions. And then more specifically, the group are asking about the data and evidence that we use as a health board to inform and monitor our decision making, about equality and equity of treatment times for Powys patients and the impact assessments and how treatment is provided on a clinical need basis. how we as a health board continue to engage with patients and their experiences, and what mechanisms we have to listen to patients and their families. They've asked about our health board governance approach and decision-making protocols, and they've also asked about the data and information that we're using in the development of our next annual plan. So if I may, just a couple of comments and then I'll confirm how we'll respond. So I am really pleased that the group had the opportunity to meet with our Deputy Director of Communication and Engagement. That meeting took place last Friday, which was very welcomed. It provided a really valuable opportunity to hear firsthand from the group volunteers and staff. That also included sharing with us some patient experience stories from people currently on waiting lists and the results of the survey that the group have undertaken that had 82 responses. So as the board will be aware, patient feedback continues to be a source of information we use in informing our development and the delivery of our annual plan and our work more broadly. So I'll very happy to confirm that we will provide a written response to all 14 of the questions. We'll provide that directly back to the Better Lives in Powys group. We will also publish those on our website alongside today's board papers. Thank you, Carl.
Thank you, Helen. Again, please do look out. So a direct response to the group, but also any members of the public or any interested people, please do look out for those responses to those important questions on our website. Thank you. In which case, we turn our attention to 3 update reports under item 1.6 of the agenda. The first is my report, and I will take it as read. I don't have any additional comments to make, but I'm very happy to respond to any question or to engage in conversation about this report. Colleagues, would anyone like to come in at this point? There are no comments or questions, in which case we turn to our Vice Chair's report. Rhiannon, do you have any additional comments that you want to make?
Thanks, diolch, Carl. Just to really say that thus far I have been really impressed with the commitment of both the leadership team and the staff that I've met, and it's come across very strongly to me that everybody is working really hard to do their very best for the population of Powys within a very sort of challenging context. So I just wanted to say that, and it was particularly pleasing to see the frailty team, which has been established, a very important area for the population of Powys, and that ageing well piece that is part of the Powys Teaching Health Board, or the Powys strategy, I should say. So just to pull out those particular points. Diolch yn fawr. Thanks, Carl.
Thank you. Gydweithwyr, oes na unrhyw gwestiwn neu unrhyw gyfraniad mewn hymateb I adroddiad yr is-gadeirydd? Any question or comment in response to Rhiannon's report? In which case, we turn our attention to Hayley's report, the Chief Executive's report. Hayley, would you like to add comment to it?
Diolch Cadeirydd, bore da pawb, good morning all. I'll take the majority of the report as read, but I did want to pull out a couple of points if that's okay. You'll see in the report, I've particularly mentioned that the Module 3 of the COVID inquiry, which was published last week on the 19th of March, we will be digesting that report. There are 10 recommendations that are set out within Module 3, which is really focused on the healthcare response during the pandemic. And those recommendations are for all governments. Broadly, the themes are around our urgent and emergency care and surge capacity response. There's recommendations around infection prevention control guidance, how we collect data, work around advanced care planning, and also guidance on critical care. I think the final recommendation is around the support arrangements for workers, for healthcare workers as well. So I wanted to particularly draw that issue out for board members, that now the governments will have 6 months to respond, and we as an NHS will also be contributing to the content of the response to address all 10 of the recommendations that have arisen through the Module 3 report. And we'll bring further information on that at the appropriate juncture through to board. The second issue I wanted to draw the attention of the board to is, as of the 1st of April, there has been revision to the Welsh Government oversight and interface arrangements, and you will see later we'll be discussing our position being in level 4 escalation for finance strategy and planning, and how our interface will change going into the new financial year in light of those revised arrangements. So again, we will monitor that as we progress through the year, and we'll be reporting the outputs from those arrangements through to the appropriate committee and board. And then clearly there's updates around particular issues in primary care within our report, and also some very good news around service developments. I'm really pleased that we were able to get confirmation from Welsh Government that the outlined business case for the hub in Newtown as part of the North Powys Wellbeing Programme has been supported, and also the launch of the Virtual Women's Health Hub as 2 examples, but a number of other service developments in the report. And then finally, we've been working with our partners across in NHS England for a number of years, and I'm pleased to highlight to the board today around the fact that Shrewsbury and Telford NHS Trust has now exited NHS England special measures, which is a huge milestone for the organisation. So other than that, I'm happy to take any questions people may want to raise. Thanks.
Thanks, Hayley. So we have some colleagues that want to come in. We'll go firstly to Robert.
Thank you, Chair, and thank you, Hayley, for your report. I've got an observation and then a request, really. First of all, on the JCC recommendation 4, I note that the JCC plan to re-engage with the population and the stakeholders to understand rural concerns, and they'll then work up a proposal, and that will be presented to the JCC later this year, as 2026. I do recall that in 2024, reading that we would receive a delivery model in early 25. So I do hope that this board will receive further or future assurance from the JCC that they're working as rapidly as possible on recommendation 4, particularly in regard of the recognition of its separation from the EMITS changes, and also recognising the interest and the scrutiny being provided by our patients and the public in Powys. That's my observation, and then my request really relates to the 2.7 million capital investment in radiography, for example, the Beam CT in Newtown. And I wondered, Chair, if we might revisit this investment in one of our committees in, say, a year's time, to measure the impact of the investment on, let's say, improved timeliness for diagnostics, and also, of course, improved access for people living in more remote locations. But I would like to emphasize this is really good news. It's part of several of key investments. It's good news for staff and good news for patients. Thank you both.
Thank you, Robert. Hayley, would you like to respond individually, or shall we take a few comments?
I'm happy to do as you see fit, but shall I respond to those 2 points quickly, if that's okay? So in terms of the delivery model around recommendation 4, as colleagues are aware, there was a legal challenge that we went through, so that work was put on hold whilst that legal challenge was being worked through. However, just to give you some reassurance, in the last Joint Commissioning Committee meeting where we received the update and it was agreed agreed that that work would come back later in the year, I also requested that a detailed work programme and timeline is shared at the next JCC prior to the work being undertaken and re-engaging with the communities. So I hear Robert's points, and that is the points that I've represented in the Joint Commissioning Committee and is in line with previous board discussions that we've had. And in terms of the radiography investment, as with all investments, we have a process where we look at the benefits realised through the investment benefits group, and my suggestion is that we schedule that into the work programme of the committee so that you can seek assurance on that those benefits have been realised as a result of that investment. But it's looking good, and certainly the feedback that we've had so far is that very, very positive. Thanks.
Yeah, I think that's really helpful. So, but just to clarify, Hayley, would that be F&P?
Yes, we can do that. Yeah.
Yeah, or yeah, I'm seeing Helen is nodding, I think. So thank you, Robert. And just to support Hayley's point, I've been up and seen the equipment and seen it working and so on. It's both impressive, but also, as you say, Hayley, the fact that people don't need to travel to Cardiff anymore and various other things. But I think your point is well made, Robert, to see the evidence, as it were, come through to us through the F&P committee will be very helpful. So thank you. In which case, we go to Simon.
Thank you, Carl. Simon Wright, independent member. Firstly, thank you for drawing out those two really positive results on service developments, and I think just to give emphasis and to thank colleagues who I know have worked incredibly hard, particularly around the North Powys development, to get that documentation into Welsh Government. So huge congratulations to colleagues for the hard work there. Two things I did want to just ask for an update on, if I could, Hayley. I'm really encouraged to see that sort of transparent and open reporting on two quite sensitive and difficult issues, the meningitis outbreak and the sexual health post and test issues. So thank you for bringing that to our attention. On the meningitis case, can I ask if we've had any cases in Powys, and if so, what actions have been taken? And on the sexual health post and test issue, would you be able to give us the sort of latest position? I'm aware there's investigations underway. Thank you.
You're on mute, Hayley.
Sorry, apologies. Can I ask Mary Bowley, our Director of Public Health, to respond on these two matters? Thanks.
Yeah, diolch, Hayley, bore da. Thank you, Simon, for two questions. In terms of meningitis, obviously our thoughts go out to the family and friends of everybody affected in the outbreak. In terms of cases in Powys, we don't have any cases in Powys. I had an update from Public Health Wales yesterday, and no cases in Wales currently linked to the outbreak in Kent. But I just wanted to say really my thanks to colleagues in local authority and also primary care, where we have distributed and taken proactive approach last week to alert sort of colleagues, but also any actions that they need to take should anybody linked to the outbreak or anybody other, cases of meningitis do occur across the UK outside of the outbreak as well, any swift action that people do need to take. And then in terms of the second query, in terms of the sexual health test and post service element there, just to provide sort of assurance that the sexual health team working with safeguarding team are linked to the look back exercise which Public Health Wales are undertaking, and we will be bringing a full report to the PECS committee in April. Element there.
Thank you.
Okay, thank you.
Thank you. And Rhiannon, please come in.
Diolch yn fawr, thanks, Hayley. Just wanted to, well, first of all, to congratulate on the launch of the Virtual Women's Health Hub. Clearly one of the Cabinet Secretary's priorities. So that is really good to see. But I just wanted to seek some understanding, I suppose, in terms of the part of the population which may not have digital access, which may not have confident digital literacy. I just wondered how we may support those people in accessing the information that they may need for ageing well in the context of women's health. Thanks.
Thank you. And I will ask Paul Hooton, our Director of Nursing, to come in on that point. Thank you, Rhiannon.
Thank you, Hayley. Thank you, Rhiannon. Yes, it's a very important point you're making around individuals who can't access or who don't have the necessary confidence to access our digital hubs. Who will, of course, be still able to access through their community care hubs, through their GP practices as well, and equally then out in the community. With our visiting community district nurses, etc., if there's any questions they have in relation to that, and sharing information from the hub with those individuals. So whilst this hub is really important to give a general access, it doesn't take away from the traditional accesses that our patients can access as well.
Thank you. So that concludes the responses to Hayley's report. So thank you once again, Hayley, for the report and you know, and all the good work that's been reflected in it. Much appreciated. So we turn our attention now to item 1.7 on our agenda, and as I often remind us that these board meetings are but the tip of an iceberg when it comes to our work as a board. And very importantly, a lot of detailed scrutiny and monitoring goes on in our subcommittees and indeed in our informal arrangements as well. But the subcommittees are crucial sources of assurance to us as a board in relation to our monitoring and scrutiny performance, and the chairs of those committees therefore are key colleagues in being both conduits and custodians of that assurance. And so the reports in this section of the agenda provide that assurance, so we don't want to repeat all the detailed discussions that have taken place in the committees. However, there is always opportunity for any board member to ask for additional assurance in response to these reports. So I'm now going to invite the chairs of the various committees to present their reports, and then there will be an opportunity for anyone to enter into discussion or ask question. And we turn initially to our Audit, Risk and Assurance Committee, and to its chair, Steve.
Diolch, bore da pawb. Good morning all. I'm Steve Elliott. I'm the independent member for finance. There are three parts to my update this morning. Firstly, there's a full report of the meeting that we held on the 13th of January, but I gave an update on this meeting at the board on the 28th of January, so I don't propose to say anything more in respect of this meeting. In terms of the meeting that was held on the 10th of March, there are no matters from that meeting requiring escalation to the board. We received a number of items for assurance, including an update on the current year's internal audit plan, an update from Audit Wales colleagues, and papers regarding the processes for tracking Welsh Health circulars and audit recommendations. And we also approved the internal audit plan for next financial year. Finally, at the meeting, we received and considered the full structured assessment undertaken by Audit Wales. At that stage, the report had been recently finalised, and as such, the management responses to the recommendations were still in development. But we've been informed by executive colleagues that all the recommendations have been accepted. At our next meeting on the 12th of May, we will receive those management responses and review the response, but also the timescales associated with them. But it is important that the board receives the structured assessment report in a timely way, and so it's appended to my chair's report today. And finally, I would like to thank Audit Wales colleagues for attending our recent board development session to go through the report and to also update us on findings and emerging themes across Wales. Thank you very much. Diolch yn fawr.
Thank you, Steve. And just to reiterate, in terms of our response to this report, that we are de facto receiving also the structured assessment report. But colleagues, would anyone like to comment or ask anything in response to the ARAC report? If not, then thank you, Steve, and to your committee for all the hard work. We turn now then to the Charitable Funds Committee that I chair. I will take the report as read. I don't have any additional comments, but if there are any questions or contributions, then please do come in. There aren't, so thank you. In which case, we go to the Finance and Performance Committee. Its chair isn't able to be with us today. Ronnie has sent his apologies. So Helen, I think you're going to present this report, please.
Yeah, thank you very much, Carl. Happy to present this on Ronnie's behalf. So just a couple of items to draw out. The committee met and considered, as it always does, our organisational escalation status report. The board will note that that's also included in our agenda a little bit later today. At the time of the meeting, we looked in depth at the finance report for month 10 and the integrated quality and performance report for month 9. Both of those in their updated form for months 11 and 10 respectively are also included in today's board's papers. We also considered the Q3 annual delivery plan. That's included in today's consent agenda for board member awareness and assurance. And finally to say, we also undertook 2 deep dive areas. One was into continuing healthcare costs and the other was in reach fragility. Thank you.
Thank you, Helen. So again, I'll pause. Should any colleague want to ask anything or comment on anything in response to the F&P report? There are none. Therefore, we invite Simon, Chair of our Patient Experience Quality and Safety Committee, to present that report. Thanks, Simon.
Thank you, Carl. So we met on the 5th of February. I will take the report as read. We have 2 items that remain in escalated status: the Children's Neurodiversity Services, where we have seen and was reported good progress is being made, although it does still remain in escalated status, and the People's Experience Framework for the reasons noted earlier in terms of the delay to that being finalised. On the Children's Neurodiversity, just to note, because it was a matter raised in the previous meeting around funding arrangements, we were updated that there has been a delay to that funding arrangements being clarified due to the Regional Integration Fund changes by Welsh Government. And as we can see later in the exec minutes, that paper did go to exec on February the 18th and is now subject to some revisions before being finalised. Also to note is that we brought the antimicrobial resistance report out of the consent agenda, which allowed the committee to discuss and take assurance around the position on secondary care. And on patient experience in in general medical services, the committee noted its concern about digital inequality that arises for Powys patients receiving treatment within the English system, and that has been escalated to ARAC for oversight and action. Otherwise, I take the report as read and happy to take any questions. Thank you, Carl.
Much appreciated, Simon. So once again, colleagues, please do indicate if you have any response or comment, question as regards the PECS report. No, therefore it too is received, in which case we go to our People and Culture Committee. Its chair, Jen, didn't chair this meeting. She was unavailable, and so its vice chair, Ian, chaired it. So over to you, Ian. Thank you.
Diolch, Carl. Bore da pawb. Yes, the meeting held on the 5th of March of People and Culture Committee. As Carl has indicated, I dept for Jennifer Owen Adams. Take the paper as read. I think the only one area I'd like to just bring to the board's attention is that in terms of the review of the terms of reference, it will come back to the board in May 26 for approval following discussion with the Chair of Corporate Governance. So just happy to take any questions.
Thank you, Ian. Once again, please come in if anyone would like to contribute in response to the P&C report. No, so thank you once again to committee members for the detailed work, and we accept that report. Now, there was a very important, later on our agenda, we will be giving substantial attention to the annual plan proposal for 26-27. I mentioned earlier how, a lot of the detailed scrutiny happens in these committees. Well, our Finance and Performance Committee and our PPPH committee met as a joint meeting specifically to look at the proposed annual plan. So initially, I'm going to ask Robert, who chaired that committee, to present feedback from that meeting. We will, of course, come back to this in a more substantial way in a few minutes' time. But over to you, Robert, please.
Yes, thank you, Chair. Yes, this meeting was on the 16th of March and it was took place in committee. We started by comparing the plan to our existing strategy, and we were assured that the 26-27 plan was in alignment with our strategy, which is, of course, a healthy, caring Powys. We also reviewed the PTHB provider and commission performance expected from the proposed plan. For example, we were assured that the achievement of ministerial targets will not be materially affected by the plan or the proposed savings. Of course, the effect of cost savings and related actions made by other health boards to whom we commission work, this of course cannot yet be determined because we're all going through the process at the same time. And we finally reviewed and scrutinised the 26-27 approach to the financial plans, which will be used to develop the route map to sustainability, and we were assured that the approach was a reasonable one. Thank you, Chair.
Thank you, Robert. And I should perhaps apologise for my overuse of initialisations. PPPH is our Partnerships, Planning and Public Health Committee. Thank you, Robert. Colleagues, I'm suggesting that I don't invite responses to this report necessarily here, because, as I say, we will be having a very substantial discussion in a few minutes on the annual plan, and it may be that, Robert, you want to come in there again, or any questions and so on that particular matter can be dealt with at that point. But we're sticking with you, Robert, for the meeting of your PPPH committee, and that was held on the 3rd of the 2nd. So please come back in.
Yeah, thank you, Chair. Some of the matters, as usual, of course, have been superseded by events, and I note that the de-escalation criteria will be considered later. I'd just like to highlight two things, really. The first is the RPB annual delivery plan, and we noted, of course, that increasingly this health board will have to focus with the RPB on exiting projects, which is a matter which might be connected with our own finances. So watch this space over the next 6 months or so. And second, the health protection summary and the summary of screening programs. Here we have some examples of prevention at its very best, and I commend these reports for wider reading. And Chair, this aspect of our work beneath our part of the iceberg is working well. Thank you.
Thank you, Robert. And once again, colleagues, are there any that would like to ask anything or make any comment in response to the PPPH report? So not least, certainly, but finally, under this section, we invite Hayley to present the report of the Executive Committee. Thank you, Hayley.
Thank you, Chair. So the Executive Committee deals with the more practical day-to-day management of the organisation, and you will see from the report that we have met 6 times between the last board meeting and when the papers were released for today. So I will take the report as read because you can see there's a substantial breadth of issues in the report, and will open up to any comments or questions. Thanks.
Thank you, Hayley. Colleagues, any comments or questions in response to the Executive Committee report? No, so thank you, Hayley. We accept the report from the Executive Committee. Again, it just remains for me to acknowledge and express gratitude for the very substantial amount of detailed work that is carried out in these reports. But before we go on, what we need to do is to go back a little bit. Right at the beginning of these papers, under item 1.7 of our agenda, we had a summary of the matters that have been escalated from the committees to the board for its attention and so on. So Helen, perhaps you might just like to offer a comment as to where we are with those escalated matters and anything that we need to be aware of today.
Of course, thank you very much, Carl. So there are 4 areas or matters that remain alerted or escalated to the board. This is really a summary of some of the things that have already been mentioned today. The first one is through our Patient Experience Quality and Safety Committee. That's with regards to some internal capacity constraints we had in the use of the Civica system. This is quite an old escalation now. Things have moved on significantly. There will be a final report going to that committee in April. And as you heard earlier on in the action log, there will be the updated People's Experience Framework coming back to the board in September. So there's nothing further to report at this point, but we expect that item to be significantly moved on, if not closed at the point of the next board meeting. The next one Simon mentioned also sits within the PECS committee, and that's our neurodiversity services. Simon's already provided an update on that earlier in this item. Finance and Performance Committee is our lead committee for our organisational escalation status. We've mentioned that across a number of committee reports, and there will also be a report from Hayley on that later on in the meeting. And then finally, Audit, Risk and Assurance Committee. This relates to the NHS Wales app and the cross-border functionality or lack of it. And you'll see for ARAC have considered that further on the 10th of March, and that has now been moved to the Executive Committee to continue conversations at executive level with NHS Wales and other colleagues. So they're the 4 items that remain escalated. We will continue to report on those. The only other thing I wanted to just quickly mention, Carl, we've been running with these style of reports now for about 18 months in the board. They've been very well received, but you may notice in some of the reports today, we've refined them a little bit further. We've tried to be more concise in some of the reports and make sure that really the key issues are drawn out for each committee. So we'll continue to work on that. But if anybody has got any comments that you want to share offline to help us continue that development, then very happy to receive them. Thank you.
Thanks, Helen. Sorry, just to go back, Helen, to the app escalated matter. So that's now been moved to the Executive Committee. And just for my own clarity, really, so we will look now to reports from that Executive Committee for an update as to how this escalated matter is being progressed.
Yes, that's right, Carl. But Executive Committee will continue to update ARAC as well. Okay. So it will be through both routes to make sure that it's clearly reported.
Okay, thank you. Thank you, Helen. That concludes the item at 1.7. So we now turn to item 1.8, which is the report of the Regional Director of Llais, Katie. So I'll invite you to come in, Katie, please.
Diolch, Carl, and bore da pawb. I'm Katie Blackburn. I'm the Regional Director of Llais. Llais is the independent statutory body representing the views of patients. We're not part of the decision-making process here today. So, members, I hope you've received my report. Just a couple of additions since I wrote it that I'd just like to share with you. Firstly, we finished our 2025-26 engagement with a public forum in Welshpool yesterday. Secondly, I don't think I've referenced, but we attended the vast majority of the Health Board's engagement events, which were at the back end of last year and the beginning of this year, which were very useful and helpful and informative. Thirdly, we've obviously like you, got changes afoot with the advocacy service and the listening to people introduction from the 1st of April. So we're working on that. And then finally, in my last bullet point, I mysteriously reference an additional member of staff, but he actually starts today. Owain Reddick starts with us in South Powys. So for the first time in a little while, we've got the full complement of staff. And I think, Chair, on that note, if I may make some observations on the papers that are being discussed and have been produced today. I have to say we've been attending the board committees on a very ad hoc basis, and my apologies for that. Now that we have got full capacity, then my intention is that we will be more regular attendees, given the importance of some of the discussions that are taking place in that forum. With regard to 3.1 and the annual plan, I would just like to thank the board for the opportunity that you gave us to join one of your development sessions at the end of last year, where we shared with you what we'd heard, and we certainly found that very useful, and I gather from the conversations and the discussions that we had that I hope you did too. But actually it's been really positive. It was a really positive experience, and I'm glad to see that reference to some of the points that we discussed during that session have actually been included and identified in the annual plan for this year. So I think that shows the impact that we have with regard to sharing what we've heard with you to help inform priorities for the coming year. So that was a very positive step forward. With regard to the plan itself, and obviously the Grant Thornton summary, I'm not going to go into specifics. There's a huge amount of information in there. Clearly, it's likely that there will be a year of change. And so I just want to seek assurance, Carl, really, that the importance of communication, engagement, consultation on the basis of no surprises from our perspective. But as I say, the devil will be in the detail, so I'm not going to go specifically into that report this morning. With regard to the report at 3.3, the temporary service change report, just to reassure members, I met with Nicola and Kate the week before last to talk through some of the concerns. We're still hearing very strong concerns and strong feelings about the fact that temporary will become permanent, and that the fact that these temporary service changes have now been temporary for 2 years. And that's very strongly coming through. I think there's an issue that we're picking up around communication. I know stakeholders and local authority members are being communicated with, but I think there's something around the actual population of those particular communities that have been impacted. People are asking, why can't they be reinstated? Why is it being delayed? And I guess, that's part of everybody's day job, but there is something about how that is communicated to members of the public. We're also still picking up that there may be some unintended consequences that have arisen due to the co-location of the ready-to-go home units and the rehabilitation units, but we are trying to understand a little bit more about that at the moment. It's just something we're picking up, but we actually are trying to unpack that. So just to give you that assurance. In the temporary service change report, Kate has referenced a brief summary of our visits, and we have had initial discussions with some of the findings that we had. Just finally on that particular report, Chair, we've had a little bit of a miscommunication between Helen and myself, just to reiterate that Llais doesn't have a role in any shape or form around clinical assessments, and the first part of that little section references Llais reporting that patients appeared to be appropriately placed for their clinical needs. We do not, and nor should we, have any responsibility or duty to comment on clinical needs. The primary care report, I'd just like to make a couple of observations. 3.4, and Hayley referenced it in her report, the fragility of dental services in Powys. Clearly that's causing a great deal of concern, and again, communication, how it's being communicated with patients. There's a lot of noise at the moment. So in the last week or so, I've asked for some clarification as to understanding the NHS provision of dental services in Powys pre-COVID, post-COVID, and the current provision. On a really positive note, in the primary care report, Elaine references clusters. I have to say, the use of Accurex, which is being piloted, I think, by the South Cluster, has been really, really positive. And I think, having had a couple of meetings with colleagues this week, it's clear that using that GP facility to invite people and to communicate with people has clearly shown an increase in engagement. So that's really, really positive. On the final comments, Chair, if that's all right, on the performance report in 3.7, I'd just like to make a couple of observations. We're hearing an awful lot at the moment about people waiting for test results. And again, I've had initial conversations with Kate about this. With regard to the WAS data that's contained in that report, I'd just like to reiterate that we hear constantly more and more people are either being advised or choosing to drive rather than wait for an ambulance. So I'm not sure that data is necessarily particularly representative of what we are actually hearing. The other point that I'd like to make is around the access standards, and the reason I'd like to make this is because it's clear in my report that access is still an issue, and yet the access standards in the performance report are showing 100% compliance. So I do think it's important to note that the access standards in the performance report, my understanding is that these relate to systems and not necessarily capacity. So a system can be compliant but still be overwhelmed by demand, and that access issue is still a top priority. So those are my observations, Chair. A couple of assurances that I would ask from yourself and the executive team and the board is around communication, engagement, consultation around the annual plan, and also around communication with the temporary service change. Happy to take any questions.
Thank you, Katie, and thank you for the very accessible and succinct way in which you've summarised your observations, and so much appreciated. I will make sure that when we come to the various agenda items during our meeting today, that we are reminded of those comments, and that the response takes into consideration those comments at the appropriate time. So, Simon, you'd like to come in, please do.
Thank you, Chair. Katie, thank you as always for your reports. It's incredibly important input, particularly around our focus on patient experience. My observation and kind of request is, it would be really strengthened if we got a sense of, I think, the volumes involved. So your report talks about a number of engagement activities. I'd really value understanding how many people were at those engagement events to get a sense of scale, and particularly then in terms of the recurring themes. How often, how recurring are those themes? Because it'd be super helpful for us to understand the sort of scale of those issues in terms of how often they're being raised with you, and then indeed we can track that over time, perhaps. So I hope that's helpful, and if those things could be included in future, that'd be great.
Thank you. Let's ask Jen also to comment, and then we'll come back to you, Katie, if that's okay.
Diolch, thank you. Jennifer Owen Adams, aelod annibynnol a arweinydd footed sector. Katie, thank you for that report. As Simon says, incredibly helpful. I'm interested to, well, first of all, great that you've got a full complement community engagement officers. Have you taken the opportunity to refresh that role in a way? It'd be good to understand. I mean, obviously, it does what it says in the tin, community engagement officers. But can you bring that role to life a little bit to understand what work they are doing and how that feedback from the public actually comes up to us, for example, and other partners? Thank you.
Katie, please.
Yes, of course. Yeah, Simon, as part of our review of this year, we'll obviously be looking at that. We've got quite a lot of stats and data. I suppose just a word of caution, it's not just about the sort of quantity, it's also about the impact on people's lives. So there might only be one or two people who are experiencing something, but the impact on their lives might be quite significant, and it may be, you know, having a wider significance on their family or friends. But I'm happy to unpack that as part of our review of the year. That's fine. With regard to the role, Jen, yes, I mean, they're our foot soldiers. They're the people on the ground. They're the people who are going, speaking to people at men's sheds or speaking to knit and natter groups or mums groups. They're the people who are there listening to what we're hearing. So they are our foot soldiers, for want of a better word, really. Fionn, who's taken over as the head of complaints advocacy and engagement, she is looking at aligning both what we hear from complaints advocacy and where we should focus our energies and vice versa. So we're trying to be much smarter in how we work this year. And as I think I say in our priorities, it's not so much about how much we do, it's about the impact that we are going to be looking that we make, really. So I'm happy to have a conversation outside of here if you'd like a little bit more information. But I now have one of those members of staff in the north and one in the south, which, as we all know, will make a huge difference to what we can actually achieve, given that they'll be spending less time on the A470.
Thank you. In which case, a big thank you once again, Katie, for the report. Much appreciated. And I just reiterate your comment earlier about the importance of the positive, constructive working relationship between ourselves. And I'm really pleased that that is in place and that we develop it further together. And equally, we were delighted when it was possible for you to join us at our board development session. It was meant to be face-to-face, but for various reasons, we had to do it online. But nonetheless, it was an important engagement. So, Katie, thank you to you and colleagues. Let's turn now to section 2 of our agenda. Nes I sôn am hyn gyne, dyma ein agenda cydsyniad, ac fel nes I esbonio gyne, dwi'n gwahodd unrhyw gydweithwyr I awgrymu bod ni'n symud eitem o'r agenda cydsyniad I fod yn eitem i'w drafod yn ystod ein cyfarfod heddiw. Just an invitation to any board colleague, should you wish to suggest that we move any item from our consent agenda to be a substantive item for consideration and discussion during our meeting today. Would anyone like to make such a suggestion? No? So when we come to that section on our agenda, we will deal with those items en bloc, not for discussion, as I've described and explained. We then, well, just before, we're going to come now to some very meaty items on our agenda, initially our annual plan for 26-27. So I think we should take a break at this point. I'm going to suggest actually that we take just a 10-minute break or just after. So can I ask please that we resume at 10:55? Thank you. Croeso nôl, and a very warm welcome back to our meeting to everyone. So we turn to item 3.1 on our agenda, one of our very key and significant items for consideration today, our annual plan for 2026 to 27. This is a very key document that guides our actions and our implementation for the next financial year. It also sets the financial allocation across the organisation for that year. The plan as well underpins our longer term strategy direction that we see in our shared strategy, Healthy Caring Powys. Very importantly, it includes for the first time an articulation of our route map to balance and to sustainability, which links, of course, with our de-escalation from level 4 escalation, and that's something that is really good to see in the document. This document in front of us today for consideration is the product of a lot of work over recent months. From a board perspective, it's been considered and been through various phases, and as we heard earlier, has been the subject of scrutiny in various committees. It's also been the subject of discussion informally at a number of our monthly board development sessions. And so we will hear also from Robert about that important meeting of our joint committee of F&P and PPPH, and Robert may want to offer additional comment as we get into this agenda item. However, I will invite our Executive Director for Planning, Performance and Commissioning to present this item, and I'm sure, Nicola, that you might want to bring other executive colleagues in as appropriate. Can I, just before you start, remind us of Katie's comments from Llais in relation to this annual plan, and she particularly was asking for assurance as regards the role of communication and engagement, and how we will ensure that we are compliant with guidelines and so on as we implement the plan during the year. But over to you, Nick, please.
Diolch, Chair. We are presenting the plan due to its complexity as it covers all of our business by means of a short presentation as a team, with Hayley leading that to start off with. So hopefully somebody can share the slides. Thank you. And I'll hand to Hayley just to do a short introduction.
Thank you. If we go to the next slide then, please. So I'm really pleased to be able to introduce the Health Board's annual plan for 26-27. As the Chair's mentioned, this year's plan is shaped by a clear purpose. It is aligned to our long-term strategy, a Healthy Caring Powys, and there's a very strong focus on how we continue to deliver safe, sustainable services for the people of Powys, whilst also being responsible stewards of public resources. We know that we're working in a context which is challenging, both financially and operationally, and this plan is about how we're setting out to meet those challenges with realism and transparency. So the plan you will hear about today is designed to strike the right balance between a number of priorities, and therefore the Health Board is planning to remain in routine monitoring for quality, performance and governance, as well as addressing the level 4 escalation status for finance, strategy and planning. You will note that we have had an independent review conducted by Grant Thornton and Partners, and our response to those recommendations are embedded within the annual plan. So the plan protects our essential services, it prioritises areas that deliver the greatest impact, and there's a very strong emphasis on prevention, early intervention, and the important work that we need to do to work in partnership across healthcare and the third sector as a system. We're continuing to shift towards a community model of care and very much focused on how best to respond to the unique needs of a rural population of Powys. And also we have a very strong focus on how we can help people stay well for longer. You'll see in the plan that there is some focus on immediate short-term, immediate recovery actions next year, but also, as the Chair mentioned, it outlines the total opportunities pipeline and route map to sustainability in the longer term. The Better Together programme is referenced, and we will cover that a little bit later as well, around that being our vehicle for setting our clinical services plan for the future. As Katie mentioned earlier, and the Chair, Llais has been really valuable in providing feedback to inform the plan, but also the process of engaging with our staff and the insight of our partners are embedded in the way in which we've shaped the content of this year's plan. So I'll hand over to Nicola now as our Director of Planning to walk us through the key components. Thanks.
Thanks, Hayley. Obviously our plan is built on the progress that we've made in 25-26, as Hayley has already explained. We take very seriously that we're at a level 4 escalation for strategy, planning and finance. And we were challenged in 25-26 with the delivery of our financial plan for that year, and unfortunately had to increase our deficit due to some of the planning assumptions changing to it, and the board made that has noted that previously. As a result, an independent report was commissioned from Grant Thornton and Partners as part of our escalation support, and that will be is appended as part of the papers. And will be referred to later in this presentation. However, the plan clearly sets out that we were intending to remain in routine monitoring in terms of the Welsh Government escalation status for quality, performance and governance, and that's building on our good progress in those domains this year, which is explained later in the board agenda, where we are in the most recent integrated quality and performance report. Next slide, please. We thank all our staff and our partners for our many achievements during 25-26 as laid out in the plan, and again those are reported on a quarterly basis to the board, with the Q3 report again later on this agenda. And these two slides, this one and the next one, summarise those main achievements in year, and again we're building on many of these into next year. For example, the successful start of a referral optimisation process for orthopaedics, our welcome high vaccination rates, the development of a population health strategic framework and commissioning framework, and many other achievements that together with our staff have been delivered in 25-26. Next slide, please. Through our enabling teams of workforce, digital environments and capital, and our very close work with our partners, both in statutory organisations and the third sector. Again, those are summarised on this slide. Next slide, please. I'm handing to Paul for this slide. Thank you, Paul.
Thank you, Nicola. As always, there's a key focus on quality in our annual plan. As you can see, quality is embedded as a golden thread throughout our planning, performance management and assurance processes. And we do this through our integrated quality and performance framework, and that enables the quality as enables quality as an organisational operational system, not just a set of projects. And important to note in this space, our focus this year on pulling that together under one quality management system. That's so we can see it, the umbrella as well as the individual components of how we manage quality within the organisation and quality assurance. Another key focus for us, as mentioned a few times earlier, is around the implementation of the NHS Wales People Experience Framework, strengthening how people's feedback and experience and intelligence are systematically captured. This is an ongoing piece of work for us, And as you heard earlier, we're bringing this back to board in September. We are currently working on a number of aspects of that, including how we ensure that in our surveys, when we're doing surveys with the public, that we ensure that Welsh we have plenty of languages available, and at the moment we've got 10 languages on our circus system to enable people to be able to complete the surveys. And we're also just about to launch our People's Choice Awards for this year as well, where people can vote on members of our staff and public that have provided good quality services and care. And equally, in preparation for the introduction of Listening to the People framework that will be embedded by September 2026, work has been undertaken to further strengthen compassionate engagement, improve early resolution and organisational learning, and ensure governance systems are aligned with forthcoming national changes to concerns handling and patient feedback processes. With that, I'll hand back to Nick for the next slide.
Thank you. So this slide, as well as the following two slides, summarise what the plan actually sets out to achieve. So this is the strategic intentions. So as Paul has summarised, to maintain and improve quality is absolutely the golden thread throughout the plan and always our first concern. There is a national emphasis on improving efficiency and productivity, and we're taking that very seriously, both in our provider services, but also in terms of those opportunities in our commissioned services. And some of the changes that we'll be making for our population and patients through this plan are improving our community model even further and community services. A lot of work has been done on that through our Better Together transformation programme. And that is very much in line with the feedback that the Llais director gave previously in terms of people desiring not to travel so far for services, and for us to use better use of digital technology. So as a majority provider of community services, our aim is to improve that and thereby reduce people being admitted to hospitals outside our borders for urgent and emergency care. And there's a lot of emphasis in this plan on that. Equally, in planned care, the work that's been done through Better Together and is still being undertaken through both the independent report response to that, and further work from the Getting It Right First team in NHS England is showing that there's a lot of opportunities again to modernise the way planned care is delivered, use our own provider services better, but importantly have different services for patients to be referred to rather than again travelling to hospitals outside our borders. And as I referred to in our achievements for this year, we have had good success in that through orthopaedics already, through a service that we started this year. So very much building on those things. Again, very much in line with our population and patients tell us in terms of reducing travel, better use of digital, modernising our services. So a lot of those will be supported through our Better Together programme, and very much through our operational teams in terms of service improvement. Many of those things, including the response to the independent report, are included for the first time in a route map to sustainability. So this plan includes the financial plan for 26-27, but also our medium-term outlook and plans to get back to a more sustainable financial position over the next 3 years. And that will require changes both in our commissioning, in terms of using best practice in many of the ways that I've just already described, and in our maximising use of our provider facilities and resources. And on top of that, we are really pleased that we're renewing our commitment to prevention in this plan, and the first year's actions of the strategic population health need framework that was agreed by the board earlier in the year are included in it, because we're very aware that in the longer term we can do everything we can as a system to be as efficient, productive and to use best practice as possible, but the population and ourselves also need help with our partners to reduce health inequalities and improve overall health in order to reduce the real demand for healthcare, particularly in Powys with our ageing population. So next slide, please. So this slide shows how many things I've talked about contribute to our short, medium term and long term actions, and I'm not going to repeat them here, but it maps those things through and shows where they are in the plan document. Next slide, please. And equally, this is a pictorial representation of that, again showing what the main drivers of our risks, our recovery issues and that longer term sustainability are, and again where and how they are responded to in the plan. Next slide, please. And I'll pass to Deb for this one.
Thanks, Nick. Just as a reminder, a little bit on Better Together. In 2024, we started to build the foundations for the programme to lead us to sustainable services and care closer to home, and taking account of current challenges with service models, workforce gaps and ageing estate. We've come a long way. We've seen many examples of where our teams have worked internally and externally together to design services that are informed by what the data is telling us and reads across to reports like our public health strategy and its focus on prevention, and includes the outputs from a range of engagement events with staff and stakeholders. During phase one, there's been significant technical work to inform the adult physical and mental health community services and their emerging options. Within the annual plan are a wide range of deliverables associated with phase one. Those other areas that meet the threshold for public consultation are being finalised and will be part of that public consultation business case that will require board consideration during the summer. Next slide, please. And then just a couple of headlines on workforce, our most critical assets. We've maintained our workforce priorities of staff health and well-being, that Powys remains an inclusive environment and therefore a great place to work. And linking back to Better Together, we have greater workforce sustainability and transformation. We'll continue to build on the success we've had of growing our own, particularly with our work on aspiring nurses, and in turn we'll need to double down to bring greater agency and variable pay reductions. We're in the process of analysing the most recent staff survey results and the actions that are needed from what our staff have told us. We already have a positive and well-developed relationships with partners, and in particular our staff side trade unions. Just on that last point, we will continue to work together as we face difficult choices in the future on workforce growth, deployment, and the careful balance that will be required between investment, but also disinvestment or restructure. Thanks, Nick. I'll hand back to you.
Thank you. And Deb has referred to that formal consultation process on those aspects of the Better Together changes that require that under the Welsh Government guidance. And obviously we would be looking forward to hearing from our partners and population staff in that process later in the year. But we very much commit, in line with the feedback from Katie, to continuous engagement with our population on all the changes and deliverables in the plan. And as I've said, the plan does respond to the feedback that we've already had, with Katie coming to one of our board development sessions as part of the development of this plan to give us that summary previously, as well as formally presenting that to the board today. In terms of the performance assessment, as previously reported under the report from the joint meeting of the FPC and PPPH committee, as a provider, we're in a good place in terms of being able to meet the Welsh Government priorities in the performance framework, with the majority high or medium level of confidence. There are two here on this slide around colonoscopy, which is a national issue, and we're working very closely with the national team to improve that, and around children and young people waiting for a neurodevelopmental assessment. We are really pleased that we have improved that service, done a lot of change in line with what the national guidelines are, and continue to engage with families and carers around that service throughout the year. There will be improvement in the waiting times from where they are at the moment of 2 years. However, it will take us longer than the whole of next year to meet the actual standard, which is set by Welsh Government, of 6 months to assessment. Next slide, please. In terms of commissioned services, in NHS Wales, the standards are 104 weeks for inpatients, which is the same as a 25-26. However, have moved to a 26-week standard for new outpatient appointments. However, all our provider health was a flagging difficulty in meeting the targets, as it has been announced that there will be much reduced central Welsh Government monies to support that backlog reduction into next year. So we're not expecting that change in target to be a financial pressure for us, and pleased that we're in a good place with being able to meet it in our provider side. We have explored some commissioner arrangements with NHS Wales with a mixed picture of what we've been able to agree, but there are controls and mitigations in the contracts for if there are centrally funded planned care initiatives. And the LTAs with a number of health boards have been amended as per the independent report recommendations, so we are pleased about that. On the basis of our close discussions with our provider health boards in Wales and Velindre NHS Trust, we were able to confirm that agreement in principle has been reached with all NHS Wales providers on our contracting arrangements. In NHS England, the NHS England planning framework continues to drive improvements in elective recovery and will continue to do that over the next 3 years. And we have issued commission intentions to our 3 main providers, flagging our intentions to reduce growth in urgent emergency care and planned care, again in line with the independent report recommendations. Excuse me, and the things that I've already outlined in line with best practice and using our own services to reduce that spend over the border, but really importantly, to provide good quality care to our patients closer to home. I won't go through all of the things that I've put on the slide here, but just to note that we will continue to commission, and the board has agreed that informally, with obviously that formal note in today, to commission to NHS Wales waiting times for the whole Powys population. And that will include working with Robert Jones and Agnes Hunt, who have the largest number of patients waiting over 104 weeks of any of our providers at the moment. And again, as a board, we have agreed to work with them to reduce that number, notwithstanding our commission intention around NHS Wales waiting times for all. In terms of the Joint Commissioning Committee, who commissions a range of services on behalf of all health boards, including specialised services, specialised mental health services and ambulance services. Following the assessment of risk and opportunities, the JCC has the Joint Commissioning Committee as a committee of all the health boards has supported a plan in principle, which includes a requirement to identify the amount of savings and efficiencies which are on the slide there. At the moment, there is a requirement for those provider savings to be developed, and our share is a small uplift over and above the uplift that has been given from Welsh Government, and we are committed to supporting those JCC arrangements, and this is currently included in the annual plan. Next slide, please. Hand in to Pete now. Thank you.
Yeah, thank you very much, Nick, and good morning, everyone. So, as has already been mentioned and referenced, our independent report from Grant Thornton and Partners, following a review of our main cost drive areas, has identified 5 key themes, and they're on the slide in front of you. They are commissioning and risk focus, governance, organisational capacity and capability, data and information, and collaboration. And in relation to those 5 themes that have come out from their work and their report, there are 5 areas of action. Those being a commission-focused organisation, to work in collaboration, to improve data quality and data flows, to focus on financial recovery and delivery, and the governance policies and processes to support those actions. From the report, there's been identified a potential opportunity for financial improvement of up to 27 million. Now that 27 million is a gross figure and recognises that in some areas where we need to invest to increase our capacity to be able to deliver some of those benefits. And the recommendations from the report have been included and have informed our 26-27 plan and our route map opportunities list, as have already been referenced. If we move forward to the next slide, this picks up on our approach to a route map to sustainability. So recognising that as our plan for 26-27 is being developed, that we are unable to deliver a financially balanced plan, we're unable to meet our statutory duty to deliver a break-even position, we've developed a route map to sustainability. This focuses on a 3-year period and identifies the total list of opportunities and actions that we can look to take to improve our financial position over that 3-year period. As you can see in the table referenced on the right, that covers a 3-year period. It highlights our starting point position for this financial year and a forecast for future financial years, includes assumptions around the likely level of inflation in growth in the next financial year and the future financial years, an estimate of savings, and an estimate of the level of opportunities that are available to the Health Board to work on to deliver financial improvement. If we're unable to deliver against this plan in totality, and notwithstanding any changes around assumptions in relation to growth and inflation, that would take us to a position which still is in a deficit, but which is within our 12 million target control total of a maximum deficit of 12 million. So a route map is basically a way of identifying all of the opportunities available to the Health Board and then working out a realistic and reasonable time frame to delivering those opportunities whilst maintaining our focus on quality of care. And that time frame has been developed over a 3-year period. 26-27 is the first year of that route map process, and that is the basis of our plan for 26-27. Absolutely worth noting that this is a live and iterative process. The opportunities identified, the benefits identified, the assumptions around growth and inflation will all be subject to change. We know that things are volatile at the moment, but there are planning assumptions within this, and our actions and efforts will be in terms of developing those relevant work stream supporting actions to deliver the benefits as targeted. And this approach will be part of our overall arrangements that we'll be implementing in terms of our financial recovery and our financial turnaround given our financial position. Now, when identifying the opportunities, this is the relatively straightforward part of developing the route map. The challenge will be in terms of the service delivery and the actions needed to deliver those opportunities. And this will require the full board engagement and the engagement of everyone within the organisation to play the role in delivering against these opportunities. Next slide, please. So coming back to how the board worked through a process of identifying our plan for 26-27 and the number of scenarios that we considered in terms of developing that plan. So the starting point for our financial ask in 26-27 is our underlying deficit. Our underlying deficit, then bringing forward our assessment of inflation and in growth and offsetting the level of funding available to the Health Board, gave us a starting point position or an ask of 67.6 million. You will see that 67.6 million included in the table under the scenarios 1 to 6 against the current assessed deficit position line. The board then considered what opportunities, what actions could be taken to eradicate that underlying deficit, to mitigate inflation and growth, and to make savings to improve that financial position. And we consider this under a number of scenarios. The first one being with delivery of a 3% savings target. The second scenario being to maintain our underlying deficit of 44.7 million coming out of this financial year. The third one to be to stabilise our position and to hold our position at the forecast outturn for this financial year at 33.3 million. The fourth scenario to improve the position. The fifth scenario to get back to target control total of a 12 million deficit. And the sixth scenario to deliver a balanced position. Now, clearly, under those scenarios, the range of savings required to deliver that increase as you go up the scenario. So a 3% savings target is 11.8 million. To maintain our underlying deficit, we require 22.9 million pounds of the savings. To maintain our position at this year's forecast outturn is 34.3 million. To deliver an improvement is a range between 34.3 million and 55.6 million. To get back to target control total is 55.6 million, and to deliver balance would be the full 67.6 million. Now, based on an assessment of realistic target, the opportunities within the Grant Thornton report as already referenced, a general savings target and other schemes, the board's plan is based on scenario 2. And that scenario 2 requires 22.9 million pounds worth of savings. This, if delivered, would be the highest level of savings the Health Board has ever delivered, and that equals 5.8% of our total funding as received. If we move forward, please. So, summarising that, just to explain that there were a great many conversations, a lot of work underpinning that scenario I just described. This leads us to this summary table, which describes our financial plan. Now, this financial plan supports the operational and service delivery models as we have included within our plan, and is as required to meet the performance targets that Nick has previously taken us through. So just to explain and talk us through this, the starting point of our plan for 26-27 is the underlying deficit, which is brought forward from this financial year. That is assessed at 44.7 million. In a very simple way of describing that, we have a forecast outturn position in 25-26 of 33.3 million, but we have a circa non-recurrent savings delivery of circa 11 million, which takes our underlying deficit back up to the 44.7 million as in the table as described. The next line is assessment of all the inflationary cost pressures on our position, those increases in prices that we'll all be familiar with in our everyday lives across our range of services, and they're assessed at 7.1 million. We then have our assessment of growth and future demand and cost pressures. That is assessed at 17 million. And then we offset for the net impact of our funding increase when adjusted for a number of top slice actions. It gives us a total in-year ask before savings of 22.9 million. So we need to deliver 22.9 million pounds of savings to hold our underlying deficit of 44.7 million. That savings target of 22.9 million is set within our plan, and it's made up of a mix of a general savings 3% target across all areas, and then an assessment of the likely deliverability against those further opportunities as listed in our route map to sustainability, and includes our general 3% target, our Grant Thornton opportunities, and further areas as identified in terms of financial benefit. This will then give us a financial plan, assuming full delivery of those savings and assuming that inflation and growth are as identified and planned for, of an underlying deficit of 44.7 million. It's important that I do reference that this position includes Welsh Government conditional recurrent cost pressure funding that we received in 24-25. So that 5 million is referenced, it's in our position and plan, it's referenced in case of any risk in the future to that conditional recurrent funding being available to us. So that is a very high level overview of the financial plan and the route map to sustainability, which supports our plan as described. Just to be clear, this is a challenging plan. Level of savings would be the highest as ever delivered in the health board, and there was a need for those savings to be recurrent to help improve our position and help to meet our aspiration in relation to our route map to sustainability. Probably sensible to pause there. I hand back to Hayley for any final remarks.
Thank you, colleagues, for taking us through the components of the plan. I think you've summarised it, Pete, but just to sort of say that in terms of the balance of the plan between safety, access, quality and finance, we feel we've taken that correct balance around the content, and also that this plan will require collective leadership across our organisation, with our partners and as a board, in order to maintain focus and to deliver that level of savings as set out within the 26-27 plan. But I'm, confident last year we delivered more savings than we ever have done, and I'm confident that with the discipline and commitment we've demonstrated today, that this plan represents both a disciplined and balanced response to the pressures we face. Thank you. Hand back to you, Carl. Thanks.
Thank you, Hayley, and colleagues. We, as I said earlier, a huge amount of work sits behind this plan and its development. And I just want to have an observation as chair of the board. I mentioned earlier that our committees and in informal development sessions, we have been shaping this together. It comes today for our final consideration and acceptance. And I just want to reiterate that the challenge we often give to ourselves as a board is, are we going far enough and are we going fast enough? And although at face value, it might just seem as though we are maintaining our underlying deficit position. Nonetheless, exactly as colleagues have said, asking the organisation to make another £22.9 million of savings within a year on the back of substantial savings that we've made in previous years is actually going far and proceeding at pace. And so I just wanted to add that observation from, as I say, from my perspective as chair of the board. But colleagues, please do come in response to the proposed plan, and we'll turn initially, or we'll invite initially Steve Elliott to comment. Please, Steve.
Thank you, Chair, and thank you, Hayley and Nicola and Pete and colleagues for going through that in some depth. And I think there's a lot of positives to take from this plan in terms of certainly our provider performance, a greater emphasis on community-based services, and particularly building in the population health strategic framework. So I think that's really all positive. Clearly, the financial outlook remains extremely challenging, and as Carl's just mentioned, we are, and Pete mentioned earlier, we are facing a significant savings ask for next year on top of what we've had to deliver this year. So the number of questions I'd just like to ask. Firstly, whether you could give an update on the sort of confidence assessment in terms of that £22.9 million savings plan for next year, in terms of where we currently stand. I appreciate that we won't necessarily have bottomed out all the plans for that yet, but just to give an update on where we are with that. Secondly, clearly the plan will have been developed over the last few months and prior to the outbreak of conflict in the Middle East, and that is likely to have significant financial implications going forward, particularly I suspect with energy prices. So I'd just like an update, please, in terms of the consideration of that and what conversations are going on at a national level to mitigate the potential impacts of the conflict. In terms of the route map to sustainability, it's really pleasing to see that. Clearly, it's based on a number of assumptions, and at the moment, we've got a good opportunities pipeline, but I just would like an update on what the delivery model is to translate those opportunities into plans for delivery. And finally, a more specific point, I think Katie mentioned earlier that a lot of our population are now choosing to use their cars to access hospital because of ambulance performance issues. So just if you could update on what action have been taken within this plan to address ambulance performance times. Thanks very much.
Thank you. We'll go back to you, Hayley, but you may want to bring in colleagues on specific matters.
Yeah, perhaps I could bring Pete in first, if that's okay, in terms of the first 3 points, and then perhaps in terms of the ambulance position. Nicola, are you happy to come in on that? Thank you.
You're on mute, Pete.
Thank you, Carl. Steve, I'll try and remember the first 3 points. So in terms of delivery confidence, I guess I'm not sure that question should come to me. Should probably come to the whole board for us with different areas of responsibility for delivering that improvement. What I will say is we're not at 100% green against the 22.9 million. We're at a reasonable position against the 3% ask that was set in all areas, and we're still working through those the actions in terms of the recommendations in the further opportunities in relation to the Grant Thornton report and other areas. So that delivery confidence will need to be improved as we move into the year. I guess the reference to the fact that we've made £21 million worth of savings in the current financial year, albeit roughly 50% recurrent, 50% non-recurrent, gives us an indication of the deliverability. In terms of energy and the impact, yes, so the plan was developed at a point in time that will potentially have an impact on our position and a need for further mitigating actions. We continue to link in at a national level with the energy group in terms of understanding how that may look and what it may mean, and to be part of the actions that that group take to try and mitigate any impact from that. And in terms of the delivery mechanism, so we're currently looking at the governance and the arrangements around our approach to financial recovery and financial turnaround, and the monitoring, performance, actions and ongoing reporting against the opportunities list as for this financial year, and the route map future years will be part of that process. So that is being finalised and worked through, and that will then be reported to the board and will be part of that. I think they were the 3 key ones.
Nicola, would you like to comment on Steve's question in relation to ambulance performance?
Yes, thank you, Steve. Members will be aware that ambulance services, as I said earlier, are commissioned on behalf of all health boards by the Joint Commissioning Committee. So we remain very much engaged in those Joint Commissioning Committee mechanisms to monitor and support improvement in both the handover times at acute hospitals and in terms of the response times. We monitor that through our performance reports, and again, we do that on a monthly basis in terms of those impacts in Powys, in terms of the impact of rurality really on, unfortunately, those longer waiting times for our population. And we continue to advocate through the JCC mechanisms for our population in that space. The actions in our annual plan are more around reducing demand for urgent and emergency care, supporting the population in a range of pathways, particularly cardiology and respiratory, and those are the preventative measures around vaccination and so forth, which will help prevent people in our county to be hospitalised for avoidable communicable diseases such as flu. In line with the planning guidance, that really close alignment of our direct actions to impact on those urgent and emergency care pathways, and to continue to try to reduce the demand for ambulance conveyance is really important. I should note that an ambulance is a clinical service. It's not just a method of conveyance, and therefore it is part of the algorithm for the call handlers in the ambulance trust, that ambulances are deployed to the patients who need them most, and that sometimes it is advised to patients that they make their own way to hospital if a hospital visit is still required. But that actual clinical services that are provided on the ambulance are not. Many actions across the course of our plan, Steve, and we continue to monitor that through our performance reports. Thank you.
Thank you. Just before I ask any further comment from Steve, I just wondered, Hayley, Pete mentioned that we've got a whole organisational perspective in terms of delivery performance, as Steve has highlighted. Wondered whether you had any observations, and indeed any other comments you want to make.
I do, and I think that we're considering a little bit later again our escalation position and the strengthened approach that we're putting in place around ownership at an executive level, escalation of risks, and also the tracking arrangements based on the Grant Thornton recommendations. I think that from my perspective, there is the work now, the urgent work during the first quarter of this financial year is de-risking that £22.9 million savings target. Clearly, we are open in terms of the confidence level, not fully worked up across all of the work, and the work will be undertaken at pace. So there still remains, as we're agreeing this plan today, delivery risk, but that does reflect both the scale of the ambition of the savings required and the operational pressures and the changing context, for example, the Middle East conflict and the impact on energy prices, etc., that we're managing at the same time. So I'd like to just give some assurance to the board around the approach that we're putting in place will involve that tracking approach, that delivery and monitoring that will be coming through to committee and boards, and also that we'll be identifying risks early. So where we have found perhaps that we might need to be flexible and find alternative options due to the changing context operationally, that we do that as early in the year as possible. So those are the additional points I wanted to raise, Chair. Thank you.
Steve, do you want to come back on any of that, or are you content?
Yeah, I mean, clearly it will be a very financially challenging year again, but I'm really grateful for the assurances. But obviously, it's something that we will need to monitor, particularly early in the year, to make sure pace is input into delivery of the savings programme. Thank you.
Thank you, Steve. Nina Davis, please come in.
Diolch, thank you, Chair. Good morning. I'm Nina Davis, Director of Social Services and Wellbeing for Powys County Council. Just wanted to acknowledge and appreciate the scale of the challenge and the work that's gone into collating the report and the plans that are in front of board today. So firstly, just a thank you for that. Really welcome the programmes of work included. In particular, just like to highlight around improving community services, reducing unscheduled care admissions, improving local planned care to deliver more care closer at home. Really welcome strategic priority 1, the whole system prevention approach, particularly in those targeted at healthy ageing and community-based falls prevention. And just want to really highlight here that the council really want to continue and to extend our joint working in these areas with the health board, as obviously our priorities are really aligned. In response to the Grant Thornton recommendations, I note the targets, efficiency targets around continuing healthcare, I think it's about 4 million for the next financial year. Note the actions to undertake clinical commissioning reviews, supportive of this, undertaking, if that's a right sizing exercise or contract monitoring function or commissioning, etc. I'm just keen to make sure that we don't get into the realms of any cost shunting. I'm pleased to see the wording that's been included is very much not around that. Not also within CHC in terms of the policy development actions. Would like to request that consideration is given where appropriate to developing joint policies within the framework, that any new developments policies take into consideration recommendations of the fast track review, that we can look at joint standard operational procedures to make sure that we're avoiding any conflict and unintended consequences. I'm sure you'll all be aware there's national work happening on CHC across health and social care at the moment, which obviously will need to be taken into consideration in terms of this work. And I also hope that the recent ADSS Cymru report as well into CHC is taken into consideration, which is asking Welsh Government and health boards to invest in CHC teams and provision and adhere to 8-week targets, for example. I note within the Grant Thornton report, there's reference to declining domiciliary care, and I assume this relates to health commissioned dom care as part of your CHC offer. Just thought it might be helpful to note that within the council, we've undertaken significant work with our providers and managed to deliver a 60% increase in hours over the last 20 years, supporting an additional 220 people at home. So very happy, to share the learning and the work that we've done within the council with health colleagues, and also to look jointly at where we perhaps address any remaining areas of provision that does not meet demand, etc. And then just a final kind of comment in terms of CHC, just we'll all be very aware of the Powys demography and the ageing population and the costs that does come to, organisations because of that. So accept actions to review commissioning policies, procedures, but just in light of the Powys demography, I do query the cost efficiency targets that have been set and would welcome the opportunity outside of board to understand the evidence that sits behind those recommendations. And where appropriately, I just want to offer my assurance and support for jointly working on the actions that have been identified as well. Thank you, Chair.
Thank you, Nina. I think your observations are absolutely crucial. You mentioned the essential importance of our joint working relationship, and we would certainly want to reciprocate that and reflect that. There's a lot you talked about working outside of the board meeting clearly on some of those issues, and I think that will need to be taken forward and very important. Hayley, do you have anything in response to Nina's observations?
Really helpful observations, Nina, and I think that the way in which we frame our response to this has got to be about how we work in partnership across the whole system to address some of these systemic issues we're facing across both health, social care and the wider sector that we work with in both the third sector and also with providers, both within Powys and out of county as well. My suggestion is that rather than responding to the particular points, that that commitment today around how we work in partnership on the development of the delivery aspects around this will be something that we can bring back through to the appropriate committee and board for assurance. And I think particularly for me around continuing healthcare, you referenced an ADSS Cymru report. Welcome that conversation outside as well. But I think it's important that the Grant Thornton report was an independent assessment, and we will be testing that in the first couple of months of this year now that the level of efficiencies identified is achievable and deliverable, and that will be the key work we'll do in partnership with yourselves, Nina. So thank you for raising the points, and I wholeheartedly agree around the importance of us working in partnership on this.
Thank you. So we've got some other colleagues wanting to contribute. I'm conscious of time, but this is a very, very important matter, and I don't want to stifle discussion or scrutiny of the plan. But if I could ask for succinct comments, and I think I might take a couple of people at a time, so that we try to operate efficiently. So I'm going to invite Rhiannon and then Robert to contribute, please.
Diolch, Carl. Yeah, just also to acknowledge all the hard work that's gone into the plan. I just feel it's important to, I suppose, pull out the reference made to the quality management system by Paul. I think that becomes even more important as we go through service change, the delivery of the financial challenges, and we need to make sure we've got the right system in place at every level in terms of being able to have early warning of the impact of some of those changes on both potential and actual harm and experience. So I know we're building on what we've already got, but I think I'm just recognising that quality management systems are relatively new to NHS Wales. So I think, that needs to mature and iterate as well. So I guess just some assurance on the work that needs to be done on that. And can I just also ask a specific question around the prevention element? It's really good, and I think we're already doing a lot in terms of shifting focus into prevention. Will we be able to track specifically how some of the resource or finance is shifting into prevention going forward? Will we be able to kind of pull that out so it's quite visible? I recognise that might be quite challenging because it'll be tied in with a number of complex things, but just a question. Thanks.
Thank you, Rhiannon. Robert.
Thank you. Nick, we have an agreement with Wye Valley on adhering to the NHS Wales waiting times. How are we going to achieve savings across the other two trusts where my understanding is that agreement has not yet been obtained?
Thank you, Robert. So, Hayley, I'll leave it to you to invite colleagues to come in response to both Rhiannon and Robert's questions and observations.
Yeah, thank you. Perhaps I would ask Paul to come in on the quality management and how we are maturing that, particularly with the lens of both as a commissioner and as a provider. In terms of the tracking of resources, perhaps Pete or Mez, you may want to come in, and then Nicola in terms of the savings question around commission services across NHS England. Thanks.
Hi, and thank you, Hayley. I'm happy to come in on the quality management system. And as Rhiannon pointed out, it's in an early development stage, both for NHS Wales and equally then for ourselves in Powys. I think the reassurance piece is that we've got a lot of good systems already in place, and we do quality and management and oversight and assurance really well. One of the challenges is it can be in different areas and different elements of our organisation, and part of the quality management system is to pull it all together under one umbrella. That's how we have complete oversight. And equally, in our commissioning space, whilst we do the performance management and we do the commissioning and contracting well with our new integrated commissioning framework, again, we need to pull that in under a quality management system as well. That's how we have oversight of our commissioning as well as our provider arms of our service. Going forward, we are working with Welsh Government and to say this is a new and emerging approach to quality management. And we have our first board development day coming up with NHS Wales in the coming month. I think it's later in April, to really understand how do we now develop and implement a quality management system. But I think we're starting from very solid ground. So that's the assurance I can give. And I'm about to do a position paper back to NHS Wales on where we are with it all.
Can I ask Mez to come in next, if that's okay? Thank you.
Yeah, diolch, Hayley. Thank you, Rhiannon. So in terms of the preventing the parental framework, we have mapped out for the next 5 years how we can actually integrate the delivery of the prevention plan as part of the route map, and with Lucy Cornish as part of Better Together sort of element of the work. And also we got quite a firm baseline of where we're currently at and what could be done year on year, if that's sort of helpful element really. We have incorporated actions within the plan this year as well, which are directly lifted from the prevention plan. Diolch.
Thank you, Mez. And then Nicola?
Yes, thanks, Robert. So with specific regards to our Commission intentions around planned care and NHS Wales waiting times, in 25-26 we did come to an agreement with both Wye Valley Trust and Robert Jones and Agnes Hunt Trust for treatments. As the board is well aware, we weren't able to come to agreement with Shrewsbury and Telford Hospitals NHS Trust. But we have used our other contractual levers in terms of the financial envelope for that contract has reflected our savings plans rather than the level of activity which the trust has at risk chosen to run at. Our relationships with those organisations and our colleagues that work in those organisations remain really strong, very positive, very mature, and we're able to have the conversations around all of the drivers on both sides. And to note that our contracts aren't just for planned care, so they include all aspects of care that our patients travel for, and we did come to agreement on all of those other aspects of care. Again, as the board is well aware, we are in dispute with both Wye Valley and Shrewsbury and Telford Hospitals NHS Trust. Wye Valley with regards to some policy elements in NHS England that are different to NHS Wales around rurality. Shrewsbury and Telford NHS Trust, particularly around that planned care issue. Those disputes have been referred to Welsh Government and to NHS England and remain unresolved, but we continue to work with those trusts positively to provide services for our patients. Our intention is to continue to do that throughout the next year. Whilst that commissioning to NHS Wales waiting times remains in our plan and therefore remains in the savings plan, which underpins the financial plan, we all three providers really willing to work for us on the more transformation elements as well that I've already described previously in the presentation around best practice, efficiency and caring for our patients closer to home. So thank you for the question, Robert.
Thank you. Rhiannon, Robert, any additional or responsive comment from yourselves? Rhiannon?
No, nothing additional, but obviously happy to support in any of those areas that we've been talking about.
Robert?
Thank you for the reply. Yes, comprehensive. I think we will probably in some of our committees be looking at the mechanics of doing that. But that's not really for consideration today. Thank you.
Thank you. So we go finally to Jen and then to Ian. And then after these contributions, we will need to conclude this item and consider the recommendations. Thank you, Jen.
Thank you. Rhiannon asked my question about the health prevention agenda, so I won't pick up on that one. I just wanted to say it's so good to see that. It would be so easy to dodge that, but you haven't dodged that, and I love the fact that you haven't dodged that. So that's really brilliant. Thank you, and let's really keep an eye on that. My second question was about Hayley, how are we going to share the plan, but particularly the implications of this plan with our whole range of stakeholders? You've already said how we're going to do that with the third sector. Nina's already said about the work that you're going to be doing together with the council. But we've got our sort of, our primary care sector, obviously our public, Welsh Government, etc. So it's not just the plan itself, but it's the implications of the plan. Could you just talk to us a little bit about how we might do that? Thank you.
Yeah,
And
really important. Oh, sorry.
so sorry, Hayley. If we just take Simon's comment
Yeah,
as well.
yeah.
Forgive me, Simon. I
it's fine.
I thought it was Ian, but
It's okay.
over to you.
Thank you, Chair. An observation, really, and a question. So it's really good to see the external review, the Grant Thornton work being sort of embedded in the plan and in that route map to sustainability. A really important observation from me certainly is that it gives recognition that rurality is a material issue for the Health Board. And my question is, given the report hasn't been able to put a figure on that, and we report regularly at board and in our committees about consequences of rurality and the challenges and the costs that rise for us, can I get some assurance that we will continue to work with Welsh Government to make sure that that factor is understood and can be taken into account, particularly as we meet the challenges of moving towards financial balance? The second observation I had was around, as I recall, Grant Thornton were tasked to really look at whether there was any actions we could take as a board to address in year to improve our financial position. And I think it's material to note that they haven't in their report been able to identify anything. And for me, I take a really strong assurance and affirmation of the actions and the strength, the focus that we have taken in year. And I just thought it was important to draw that out as well. So I hope that's helpful. But the question around rurality is one I do think we need to pursue with Welsh Government. Thank you.
Thank you. Back to you, Hayley and colleagues.
Thank you. So back to the point that Jen raised around how do we share this plan and its implications. On the first step is the board needs to today take a decision to accept this plan for submission to Welsh Government, and that will stimulate ongoing scrutiny and discussion with Welsh Government in the context that I wrote to Welsh Government last month to say that this plan is not balanced and doesn't meet our statutory duty to break even. So that ongoing connection with Welsh Government will continue over the next few weeks as we decide on the submission and the content of the plan today. In terms of the usual approach with the public, back to the public, we tend to do an everyday version of the plan and set that out so we've got clear information that's shareable in a more easier format than the whole plan and the technical appendices that we need to consider as a board, and that will continue and that will be available to the public. And obviously in terms of our key partners, that we will continue to share both in the NHS family with our, as a commissioner, with the providers. We have the ongoing conversations with them around our commissioning intentions, which we've discussed, but we'll also, now that every health board will have submitted their plans in Wales by the end of this month, be doing an assessment of that to understand that there are additional implications we need to be considering in light of each of the individual health boards in Wales approving their plans. So there's a lot of work around communication, engagement, and the implications with a number of stakeholders, from general public, everyday version, up to then the more strategic conversation around the fact that we've currently got a plan that doesn't meet our statutory break-even duty with Welsh Government. So happy to share that with you through the committees. We track that engagement, that continuous engagement, conversation and comms approach, and we'll be able to provide further assurance once the board considers it today around how we will move then into implementation of the plan and the delivery planning against that. I think Simon's points are really important, and I didn't want to lose that. The independent review in drawing out that there were no additional in-year opportunities this year. I feel that's an important aspect, as Simon's pointed out, but also that the rurality factor, just some assurance, we will continue to look at whether we can find further evidence and information to support those conversations, both with Welsh Government but also with our partners around that. And I know that we've had some strategic conversations, for example, with the local authority, with Nina, with Emma and the leader, about how that can be consolidated across the public sector footprint in Powys. So more work to be done, but some assurances that recognition of both our demographics, our ageing population, and the particular additional issues that we face with the rural shape of our services is something that we'll continue to raise the profile of with Welsh Government and the incoming government after May.
Thank you.
Thank you.
Jen, do you want to come back on anything? Simon?
No, I'm reassured. Thank you.
Thank you both. So we come to the recommendation. We have a very long composite recommendation, quite rightly so, in response to this, or rather connected with this agenda item. I don't intend to read it all out. It essentially comes in two sections. The first section are recommendations that we are asked to recognise, take assurance from, note and accept. Although I won't read them out, they are as read and very, very important, not least because this plan still doesn't get us to where we need to be. We recognise that it is a very, very ambitious plan with a savings target of 22.9 million, but nonetheless, we do fall short of considering a plan today that meets our statutory duty. So those points are really important. The last three bullet points of the composite recommendation are the ones related to decisions we need to make. And so I will draw those out specifically. And the first is that we accept the annual plan as our own organisational plan for the year ahead, and we support its submission to Welsh Government. Second, we delegate the final sign-off of the plan to the Chief Executive and to me, acknowledging that minor amendments will be made prior to submission to Welsh Government. And finally, that we receive the annual delivery plan as part of the annual plan, and we take assurance that this forms the basis of the quarterly review, monitoring and reporting cycle of progress against the plan. And just before I ask people to support or otherwise that recommendation, we do have some colleagues, as I said earlier, that are not with us today because they can't be with us today. Because they're not with us, of course, they can't therefore be part of this decision-making process. However, I have received communication from Cathy, independent member colleague, who says that she supports this recommendation, and also from Mick Janassi, and Mick sent a comment that I will read out. Mick says that I am content to support the annual plan. It provides the most responsible and least harmful option available in a very difficult year and offers a clear, honest assessment of our position. The strengthened narrative on financial recovery, commissioning, better together, and risk mitigation improves its credibility and coherence. It's a solid plan in the circumstances, but its success will depend on sustained grip and disciplined delivery throughout the year. So, as I say, those two colleagues are not part of the decision-making process today, but I simply wanted us to note their observations and their contribution. So, colleagues, would you please indicate if you don't support the recommendation or want to make any further comment about it? Nobody is indicating, so that is supported unanimously. Thank you very much. We turn our attention now to item 3.2 and the capital programme for 26-27, which Pete is going to introduce to us. Thank you, Pete.
Thank you, Carl. So, noting that this paper has been to a number of forums, groups and committees prior to coming to board, I'm going to keep everything at a very high level. So the purpose of the paper is to improve the discretionary capital programme for 26-27, and to note the general update in relation to capital. Pleasing to note that our discretionary capital allocation for 26-27 has increased to just over 3 million, to 3.032 million. That's very welcome and is a significant increase compared to just a couple of years ago where our allocation was circa 1.4 million. If you look at the table on the bottom of page 2 going into 3 of the actual report, you can see the summary of the total capital programme for the next year and the year after, which totals 9.6 million and 21.2 million. Also included in the report is the plan for the use of the discretionary funding, the discretionary capital of 3.032 million. That's set out in summary in the paper with the key areas of spend, and also in more detail in the supporting appendice. And as I said, noting that this has been through a number of forums and committees, I will keep it at a high level and open to any questions. Thank you, Carl.
Thank you. So Ian, please come in.
Yeah, thanks, Chair. Thanks, Pete. Ian Thomas, independent member. Yeah, Pete acknowledged that the paper's gone through the significant process to get to where we are today, and I recognise that fully. But I'm just seeking some further assurance, really, and it's a similar point that Steve made in an earlier item around the annual plan. Since this has gone through the process that it's gone through, there has been some events globally that have happened, and I'm talking about the situation in the Middle East, and those global events could end up, if we go certainly by our experience with the pandemic, in raising costs of things that could currently be in this programme. And I was just wondering, really, whether, and we need to be aware of that, I'm sure you are, how are you going to respond to that, should that happen with cost rises? It's good to see that, you know, you do have a prioritisation list within this in this paper, and that's acknowledged. But I mean, things like, you know, how will we prioritise if things start to get so expensive we can't afford all of them? That's the kind of the basic bottom line. And then some further assurance that we will concentrate on ensuring that we do meet our legal and statutory duties. So, for example, anything around fire risk and asbestos would be 2 examples of that. So I'm just seeking some further assurance, really, but I do acknowledge this has gone through a significant process in order to come to the board today. Thank you.
Pete.
Yeah, thank you, Ian. Really important point. So what I would say is that in any year, not without the current circumstances, which have potential volatility in terms of prices and supply, etc., there are those potential risks to our plan. So there is regular ongoing monitoring. There is a prioritisation process, but any significant change in prices would lead to another review of where we are, our plans, our processes. There is a small contingency included in those plans, but if that was insufficient to meet any significant increases in prices, we would have to undertake that exercise as described. So it's a really important point. As part of the process, any of those sort of regulatory legal requirements are given priority. So it would be a case of prioritising those and making other decisions. So it is a plan. It will always be subject to the need for changes in actions, mitigations, responses, depending on circumstances. So really important point. And the Innovative Environments Group and the Capital Control Group regularly review where we are, where the spend is, any forecast overspend, slippage, any changes in prices, and they take action to react to that on an ongoing basis.
Thanks, Chair. Thanks, Pete. Yeah, thanks, Chair. That's good to know. Thank you.
Steve, please come in.
Yeah, thanks, Pete, and really good to hear about the extra capital we'll be receiving next year. And I think that's just testament to yourself, Wayne, and the rest of the organisation really in delivering against the capital programme. There's reference to backlog maintenance of 69 million. I'm just wondering, has an assessment been made in terms of how this proposals, particularly around the discretionary capital, but also around the use of the TEF funding, will impact and improve our backlog position, the backlog maintenance position. Thank you.
Yeah, thanks, Steve. So we obviously any action taken will improve that position. I haven't got an analysis of what it's likely to mean to that final figure, but that is something I can take away and bring back to relevant committee and update on a regular basis.
You content, Steve?
Yes, that's fine. Thank you.
Okay, thank you. There are no further questions, and therefore we are asked to approve the proposed capital programme. Once again, if anyone wants to dissent from that or offer further comment, please indicate. That therefore is approved. We now go to item 3.3 and to the temporary service change report. And just before I invite our medical director, Kate, to present this report, I just want to remind us, Kate, of Llys's comment as regards this particular paper, who want us to note the strong feelings that there still are within the community, and a lack of understanding as to why things can't be reinstated, and also about any unintended consequences. So perhaps in your comments and so on, perhaps we could just bear those representations in mind. Thank you, Kate.
Thank you, Carl, and good afternoon, everybody. So yes, I'm very happy to present the latest summary of the monitoring and evaluation of the temporary service changes. I'd just like to thank the staff that have worked on this, both the innovation and improvement team and all the operational staff who've helped to provide information. There's a huge amount of work goes into gathering this information and rigour, and so just huge thanks to them. I'm going to try and be brief, but there is quite a lot of important information. I'll just try and pull out the most important aspects as we go through. As Katie said, there is, there is still not right across the county. I think we're seeing pockets of significant concern and from the feedback, and areas where there's maybe less concern. But we are very aware of that, and that's why it's really important that we've been continuing to engage. And the paper describes really a wide-ranging programme of public and stakeholder engagement that's taken place since November 2025. So just to summarise, there were 13 community drop-in events. Along with that was on a wide range of issues, but temporary service changes was a significant sort of agenda item for that. There's been outreach by the community comms and engagement team to community groups. We've had news updates and discussion papers, and then targeted emails at key stakeholders, including primary care, social care, the third sector, and then obviously closely working with CLICE and considering their feedback very carefully. So we continue to seek the feedback, and I think it's important to say that feedback is really important and has been a focus. We have a monitoring evaluation, but what we've done in providing this paper is there's been focus on the areas of concern that have come from the feedback, and I'll try and address those as I've gone through. So just to update that we did an impact assessment at the beginning, and that's been reviewed and has not changed. So now, first of all, to focus on I won't sort of revisit the reasons for the changes, because I think we're all very, very aware of that. But just to focus first of all on the minor injuries units. So one of the issues was that we were having lots of ad hoc closures. So to summarise the findings of the evaluation, so compared to 40 ad hoc closures, last minute closures in 6 months in 2024, there's been one closure since the changes have been introduced, and that was due to an unpredicted single staffing issue. There has been improved cross cover between sites, which has allowed better sort of peer support, peer review and education. The phone first model continues to be promoted, which is really important to make sure that patients get to the right place at the right time. There've been no out of hours incidents of harm as a result of the service changes. The 4-hour target continues to be met. There's been no agency use, but occasional use of bank. There's been no evidence of increased attendance in emergency departments. The cost per patient has decreased. There's good patient feedback. There have been no data due to candour or concerns related to the opening hours changes. There's been improved staff experience, elimination of lone working and improved training opportunities. We've received no comments from other stakeholders. So the summary is really for the minor injuries units that the benefits have been maintained, and it's therefore recommended that the changes remain in place until decisions are made through the wider decision making around the Better Together programme. Moving on to co-location, which is the ready to go home units and the rehabilitation units. Again, won't rehearse all of the changes, we're aware of those, but just to remind us that at the outset, about 40 to 50% of our patients were clinically optimised, with a mixture of patients on sites, leading to an inefficient staffing model and lost opportunities to provide intensive rehab for those patients most needing it. So again, and I think, I think we're aware that more latterly, the concerns are related mainly to the ready to go home units. So I'll try and focus on, again, the areas that have been raised. So to summarise the evaluation, then length of the stay continues on a downward trend, and we know that's really important, both in terms of outcomes, but also in terms of efficiency of our service. In terms of repatriation of patients, then it has been variable, but the tables in the paper show a marked downward trend on repatriation of patients from across the border in England. So with a marked reduction in cost for out-of-county delays from England for both community hospitals and DGHs. When you add those figures up, by my calculation, there's circa 870,000 saved over 18 months, which is significant. GP direct admissions were a concern, as in the ability to direct admit. There has been no reduction in GP direct admissions. There's no evidence of reduction in palliative care admission and provision. There's been sustained decrease in bank and agency costs. Staff turnover has been raised several times as a potential unintended consequence, and that is still perceived. That's been looked at really carefully, and I'm assured, and the Temporary Service Change Programme Board is assured, that any staff that have left for other reasons, either career development or personal circumstances, rather than as a result of a temporary service changes. Patient reported experience is consistently good. Outcome measures are something that we have, in honesty, continue to struggle with. So that's patient recorded outcome measures. There has been additional training and support gone in for staff, but we're not still seeing the volume of evaluation of PROMs that we would like. That is a wider system issue and is being worked on in a wider piece of work. In terms of evaluation and outcomes, and SNAP data for stroke patients is another area that we know prior to implementation that we were not fully compliant with. The SNAP data is submitted to independent organisation that has been submitted, and once we receive the feedback from that, then we will be able to report on the outcomes. But the evidence we have is that the patients who need it most are continuing to receive that intensive rehabilitation. Travel times have been, and increased travel has been repeatedly raised as a concern. We've looked at travel times and they are comparable to pre-temporary service change times. Stakeholder feedback, we captured in November and December. Again, travel times and alignment to social care to facilitate timely discharges were raised. A primary care stakeholder outlined a few areas of concern around flow, patient impact and workforce morale. All of the areas were looked at with a significant amount of scrutiny, and we've been unable to find any evidence to support the concerns. I think it's important to say that that things like travel patients still had to travel prior to these changes. So there will be instances where people are travelling around the county, etc. And there will be instances where it could be perceived that there were problems. But in terms of our evaluation data and carefully looking, then we can't see a trend that's attributable to the temporary service changes and no increase in any of these areas. Underuse of beds in the ready-to-go home units has been addressed or raised as a potential problem. We did have a time during last summer when there were some of the beds in the ready-to-go home units were unoccupied, or that was related to a period of decreased demand when we had a marked reduction in out-of-county delays. As the out-of-county demand has risen, then those beds are now occupied. And I know when Powys went to the ward recently, the beds were nearly all occupied, and that continues. In terms of therapy, then we know that the patients who most need the therapy and the intensive therapy are now receiving it on the units. There is a perception that there is a lack of therapy availability to the ready-to-go home units. That has been explored in detail and can confirm that the appropriate therapy measures are in place. What is clear is, and the mechanisms are there, so we are confident of that. I think what is clear is the perception still remains that it's not available. So there is more work to do, and we're recommending that there's more work to done in terms of engaging staff and patients in explaining the therapy provision, which we know is appropriate. So that is an action. Just to carry on for a moment, then third sector feedback has been positive. Social care feedback has highlighted issues with difficulty and capacity for assessments and the assessment process. Powys has provided the feedback, and I think most of the areas have been addressed within the evaluation. Some of the areas that provided with transport, waiting for care packages and availability of staff. And again, the numbers, I think because of when the visits were done, the numbers of patients that were interviewed were very small. But what we've done in that instance is triangulated that feedback with the other evaluation. So the summary is that after significant scrutiny, especially of those areas of concern, we have found no evidence of harm. There is evidence of ongoing benefit. It is impossible to say that all of these benefits will not be completely attributable to the temporary service changes, because we continue to make improvements across the service. But what we are seeing is sustained benefit, and therefore the recommendation is that the changes remain in place until the decision making is made in the wider model for Better Together. Just the last comment is that the evaluation has been significant and ongoing now, and no evidence of harm has been found. So we are suggesting that whilst we continue to monitor and evaluate, then in terms of formal reporting, that we cease to do that, but obviously would report by exception if there are areas of concern we feel the board needs to be made aware of. Thank you. I'll stop now and take questions.
Thank you, Kate. And just on that point that you finished with, just a reminder to the board that we last considered this item back in November 25, and we did agree and decide then that the formal consultation around the temporary service changes will be incorporated into the engagement and consultation associated with Better Together. So I don't necessarily want to open that conversation again, I think, but we also, of course, asked for the further update that we've received today from Kate, and therefore I will open that now to discussion. So we go firstly to Robert.
Thank you. Excellent report, Kate, and very clear. Great to see the greater stability of the MIUs, and this means that this facility will be there when we advertise it to be there, and also, of course, the reduction in agency staff. Chair, just picking up on your last remarks, we do, of course, look at delayed transfers of care in detail in F&P. There's a particular aspect of that here. which is the bottlenecks to repatriation from this service. And my suggestion is that we keep that heading, if you like, but transfer it over to that committee to review it when we do on the other transfers of care. But I wouldn't want to lose an analysis of what exactly are the bottlenecks, which, if you like, mean that our ready to home units are not performing even quite as well as we would like. Thank you.
Thanks, Robert. Kate, any response, or you might want to refer to one of your exec colleagues, particularly in terms of Robert's suggestion that we have an awareness of this in F&P.
I agree. I mean, I think, you know, if we just look at, well, we know about the quality and the outcome impact of delayed transfers of care, which should be our prime function and concern, but just looking at the cost of out-of-county delays, and given the conversations we're having about finance and efficiency, then absolutely this must be, and it is absolutely on our radar and we're driving it down, but we need to be assured that we're doing everything we possibly can. So I would agree with that.
Thank you. So once again, I'm going to invite Rhiannon and Ian to come in together, but we go to Rhiannon first.
Diolch. Thanks, Kate. I did take a lot of reassurance hearing your update there. Obviously, I haven't had the opportunity yet to be in the Patient Experience Committee and all the assurance that comes through there. I suppose I was just left, so great that you're going to be working on the PROMs further, or the patient reported outcomes. I think that's obviously really important. You know, on paper, it sounds like the very right thing to be doing in terms of, you know, reducing deconditioning and getting people ready to live well back at home. So I'm left thinking about the communications bit, and I'm left wondering what we haven't yet done in that context. And I'm just wondering about, you know, whether there's a role for behavioural science to help us to inform how we kind of put together our communication approach in that, because something's not getting through, something's not having the impact, not just on this, probably also on the minor injuries unit. So I'm just wondering if there's an element there that we haven't yet looked at, and whether that's a possibility. Thanks.
Please come in, Kate.
Yeah, so thank you. Very good question. I think what was really heartening was that this was, in some ways, this was a significant change for staff. The change, but they embraced it in terms of the concept of the ready to go home units. The staff absolutely embraced it. It did change, so the staff have become much more active and expert at mobilising people and getting them home. I think there's more to do, and I think you know, one of the things is I mean, we need to ask ourselves the question: why they're not at home? If they're ready to go home, why are they not at home? So yes, and I think you know, we've got a very big county. I think lots of this is about sort of relooping, repeat messaging, and just and repeated engagement, continuous engagement, and that's all of our jobs. There may be an aspect for behavioural scientists as well, but I think a lot of it is just really careful listening. Really important to listen to concerns, feedback, as I hope we've tried to do, that we've really looked at them, and that this is the right thing to do, presenting evidence that this is improving, and that's how we really start to change behaviour, not just for our staff, but for our population as well. So I think continuing to present the evidence that we have is really key.
Can I just come back, Carl? To be honest, Kate, it was more around the service users, the patients, the people in our community that that was particularly in my mind about the communication. And there's a model called COM-B in the behavioural science space, which I think would be perhaps a useful tool to use for a lens to consider our approach to comms in this particular space. That's what's going through my mind. Thanks.
So we need to move to the recommendations, but I will invite Chris to contribute before we do that. Thank you, Chris.
Thank you, Chair. Chris Walsh, Independent Member, Local Authority. Again, Rhiannon is still part of my thunder, because I was looking at the engagement and getting feedback from patients, and it mentions then that there is some consideration around digitalization, because some of the collection of that feedback is done manually, and I just wondered whether that's been progressed or not. But then the other aspect comes in is, bear in mind with the report that we had from Katie earlier about the public and having the engagement on there, because I do hear concerns being raised and questions on there. And it's really positive to hear within this report there is an evidence base coming through to show that there is a benefit across the board. But it's how we looking at how we do communicate and get those messages across in review of some of these services, because as further service change comes through, this could be some lessons learned, and I just wonder whether there is anything that you've taken that can inform better together moving forward.
So back briefly to you, Kate, please.
Yeah, thank you. So I might need a colleague to help a little bit with more detail on the Civica and the digital feedback. But in terms of we have had the engagement events. Some of them were really well attended, which was excellent. Some of them were less well attended, and I went to a couple of them. So we've continued to try and be out listening and talking to people, and I think that's really, really important. And I think that's just, again, an ongoing conversation. Obviously, we'll be doing a lot more talking to people as we develop the model and finalise the model for Better Together. Equally important, and yes, absolutely, this is a lot of work, but it is rich learning, and it's telling us about our system, and absolutely is informing some of the work of Better Together.
Thank you. You can take Chris. You're on mute, Chris.
I think it's in some ways is around how we do things around co-production, how we actually engage and using key partners along the way as a part. But yes, I'm content, Chair.
Thank you. Okay, so I'm going to move to the recommendation, which is that we receive the further review of the temporary service changes, and we agree, based on the review, that the evidence continues to support the retention of the current temporary service changes until decisions are made through phase 1 of Better Together. Once again, colleagues, if anyone wants to comment on the recommendation or indicate that they don't support it, then please do. That too is supported unanimously. So item 3.4 on our agenda is the primary care summary report. And just before I invite our Executive Director for Primary Care, Elaine, to introduce this report to us, can I just say that I'm particularly pleased to see this report. It's a new type of report to us as a board. And as colleagues may remember, in our 2024 structured assessment, one of the recommendations was that we as a board, it would be to our benefit to be more cited on primary care. And since that recommendation was received, we've done a lot of work in terms of our committees scrutinising the aspect of primary care appropriate to those committees. But today, for the first time, we have this overarching report on primary care for our awareness and consideration as a unitary board. And so once again, I think this strengthens our monitoring and our citedness on what is a very, very crucial area of service delivery for us as a health board. So really pleased to see it. And without any further ado, I will ask Elaine to introduce this to us, and also to introduce Jane, who I think probably is going to contribute as well. Elaine, thank you.
Diolch, Carl. Thank you. Good afternoon, Prynawn da, everyone. I'm Elaine Lawton. I'm Executive Director of Primary Care Community and Mental Health. And my colleague Jane Lawrence here with us, who's the Assistant Director of Primary Care and is responsible not just for pulling this report together, but the ongoing monitoring and liaison that we do with our primary care colleagues. I wanted to just pull out a couple of things. We won't share the slides and go through them in detail, taking them as read. But I wanted to, I suppose, reinforce what Carl has just said. So primary care within Powys is a significantly large portion of the care that we provide directly to our population. And if we consider that the healthcare that our population receive, both in terms of our externally commissioned services, our provided services and our primary care services, primary care probably delivers around about 90% of the episodes of care that our population receive. And therefore, it's a real critical point of importance for our population. And I would refer back to some of the comments that Katie from Llais made earlier, particularly around access to primary care services and concerns when issues happen within primary care that lead to contractual change. So we had some issues raised earlier, specifically around dental changes and concerns about dental changes, but it's not uncommon for us also to have those conversations, particularly around general medical services, our GP providers, as well as our community pharmacy services. So this report really outlines for us the mechanisms that we have in place to assure ourselves that contracts are being delivered as per the terms and conditions of those contracts, and that we are monitoring and overseeing those effectively. So